Hello, hello. As people are coming in, I am going to go ahead and put the screen on a PowerPoint. We'll give everybody a few minutes to get situated. The event actually begins at 8:30. So bear with me. I hope everybody is looking forward to today's event. Let's see. Okay, we have several more people coming in. We actually don't start until 8:30, so we've got a fair amount of time. I'm going to go ahead and turn my video off while I admit people. As people are arriving, if you could go ahead and mute your mic, we'll begin at 8:30.
Good morning.
Good morning. As people are coming in and entering the waiting room, if we could have all mics on mute, we will get started at 8:30.
I have a question. Hello?
Hi, thank you for your patience. I'm trying to admit people as they enter the waiting room. Can you enter your question in the chat?
Actually, I just tried to enter myself in attendance and hit the wrong button. So I didn't enter myself, so I just didn't know what to do.
I think that we've had that question in the chat already. And how about we go over that as we start the event today? Because I know everybody needs credit
All right,
for it.
great. Thank you.
Uh-huh. Oh. I just muted myself. Good morning. I hope that you all can hear me. My name is Susan Lee, and I will be facilitating today's event. If you will bear with me while I get oriented and a few other people come in. Okay. I would like to Welcome everyone to the Mental Health America and Spartanburg Regional Healthcare System 5th Annual Mental Health Symposium. This is the first year we've done our virtual format. Normally we have a lovely in-person gathering with some fellowship opportunity. In the spirit of 2020, we are being flexible and making do, and we're doing things a little differently. Mental Health America's mission is to promote positive mental health, to raise awareness about mental illness, to reduce stigma, which prevents seeking treatment, and to begin the community conversation needed about these issues. This local organization is working hard to bring innovative educational opportunities to Spartanburg County residents. We do this through several avenues. One is our bi-monthly Lunch and Learn events. We have one coming up in November, and information will be shared about that today as we go throughout the day. And then our 2021 series has not been finalized yet. Another way that we do that is through this mental health symposium. All of our events offer the opportunity for continuing ed credit for licensed clinical healthcare providers. Spartanburg Regional Healthcare System takes care of that for us. We have some wonderful partners in Nelda Hope and Toya Hancock, and they are with us today. I will let you know that you will see some screens with instructions, some slides during the break that have instructions on how to obtain CE credit. That information will also be distributed to all attendees. So as you see those slides, please don't feel like you have to hurry and take notes. Just read that and know that that information will come directly to you. You will need to complete a survey in order to get that certificate, and that all of that instructions will be sent to you. So at this time, I'm going to give a few more minutes for others to join in. We have quite a large crowd, so if you will bear with me, I'll get folks situated and get ready for our speaker. In the meantime, if you have any questions, please use the chat. If you are not familiar with it, there's a button at the bottom that says chat. If you click on that, you should have the opportunity to type questions in. We already had a question about signing in. You know, sometimes these Zoom meetings, virtual meetings, sign us in as the last person who used it. We do have everybody who registered. Let's see, we have a question. Are we already signed in? Yes, you are technically signed in. Does that answer your question? Yes. Okay, great. So even if you're listed as, you know, your son's name because he used the Zoom app most recently, you are the one that's registered, and that's the registration name for the for CE credit. So if you'll bear with me, I'm going to pause my video and put the agenda back up while I get ready for the first speaker. Okay, we have a nice sized crowd here today, even if we are not together. Again, a reminder of the group chat. The button is directly under the video in the middle of the screen. Please type your questions and comments there. My name is Susan Lee. I am with Mental Health America, a member of the advisory board, and I will be facilitating today's meeting. Mental Health America of Spartanburg is a nonprofit organization that seeks to offer information, education, and advocacy on mental health issues in our community. Mary Miles is our advisory board chair, and our other advisory board members are Vanessa Thompson, Sally Owens, Peter Moore, Nelda Hope, David Cato, Kathy Emmerth, Kristen James, Jim Rentz, Mary Hope Rhodes, and Casey Sims. We are in the process of an executive director search. Information will be shared about that opportunity today, and it will also go out with the other information on how to get CEUs. So if you have questions about that, you can certainly reach out to any of the Mental Health America advisory board members. Also, we have our website, mhaspartanburg.org. We have our mission, our events, and all that information there. We are also on Facebook. One of the things that you can see on Facebook, in the past, we had, last 2 years in June, we had a lovely fundraiser at the home of David Cato. Unfortunately, due to COVID, we could not hold that this year, but we hope to in the future. We are a 501c3 nonprofit organization, and our advisory board is, of course, all voluntary. The agenda has been shown, and this is the way the day is going to work. Our speakers will start promptly at the times as listed on the agenda. I believe this was sent out through Eventbrite. Everybody should have a copy of this. And it will be posted between sessions and on lunch as well. Our speakers are experts in their fields, and they're donating their time to share their expertise and their time to educate other clinicians. We're grateful for this, their time and expertise. Let's see. If reminder of virtual meeting etiquette, if everyone could keep their mic on mute, we would prefer questions in the group chat. Toya Hancock is helping to monitor that with me, and we'll be making sure that these are brought to the attention of our speakers. If you'll bear with me, I am going to bring up a couple of our slides as we have a few minutes before our first speaker. Let's see. This is our agenda for the day. As you can see, our first speaker starts at 9. We have a short break in between, and at 10:10, our second speaker will be speaking. Our first speaker is Roger Williams, who is with Spartanburg Area Mental Health Center. Our second speaker is Lori Bishop, who is with Piedmont Care. Then we have a short break. Then we have our third speaker, who is Courtney Bergen with Spartanburg District 6. We do have a lunch break, even though we won't be fellowshipping and lunching together. So I hope everybody will have some yummy lunch meal and company for that. We will rejoin at 1 o'clock, and we will have Dr. Shaquinta Richardson, who is with Building Bridges Family Therapy. At 2 o'clock, we will have a break, not a beak. Sorry for the typo. And then at 2:10, we will have our final speaker of the day, who is Carson Rogerson with Spartanburg Regional Healthcare System. Let's see. Okay. Okay. So again, welcome to all. This event is sponsored by Spartanburg Regional Healthcare System. They are providing the CEUs, and it's brought to you in conjunction with Mental Health America of Spartanburg. The planning group for this event today: Toya Hancock, Nelda Hope, Erica Johnson, Mary Miles, Sally Owens, Vanessa Thompson, and myself, Susan Lee. Our presenters are Courtney Bergen, Lori Bishop, Shaquinta Richardson, Carson Rogerson III, and Roger Williams. We've already gone over the agenda. Here's a little bit more information about Mental Health America of Spartanburg. Our mission is to promote positive mental health and ways to maintain it, educate the community about mental illness to reduce stigma and encourage early diagnosis and treatment, create awareness of available services and how to access them, advocate with and on behalf of consumers to ensure they receive needed services and treatment, and work with elected officials to secure adequate funding for treatment options and other services supporting people with mental illness. Oh. Again, this is the slide that goes over learning objectives and the process, a little bit about the continuing ed credit. This information will be sent to you, so please don't feel like you need to hurry and write anything down. What I would like to call your attention to is Toya Hancock, her contact information. Toya, can you put that in the chat, please, your email address? If anybody has questions about continuing ed credit, please reach out to Toya. She is working with Nelda over at Spartanburg Regional in order to get that credit. Our November Lunch and Learn is Perspectives of Mental Health and Religion. Our speaker will be Dr. Ebony Gaffney, who is the medical director at Spartanburg Area Mental Health Center. We had originally planned for Dr. Jennifer Parker, and her event is being rescheduled for the spring. The November 12th event will be 12 to 1, and it will be via Zoom. So let's see where we are. All right, Toya. I see your name. I don't see your email address. Can you put your email address out? I think it's tlhancock@srhs.com. Is that right? No, I don't see the reply. Let me confirm her email address. Yes, it is tlhancock@srhs.com. Also, normally when we have our meeting together in person, our symposium event, we have done it the prior 4 years at the Piedmont Club with a lovely luncheon. Unfortunately, we can't do that today, but we will still have something that we've offered in the past, and that is some drawings for door prizes. We will be doing those later this afternoon after the end of our last event. Thank you, Toya. I see you've put your email address and your phone number. Toya is the interim CE coordinator, so if you have questions about your CEs, please reach out to Toya for that. Again, information on that process will be sent out to all here shortly. We've got a few more people in the waiting room. I'm going to admit those. So it looks like our current total is 57 people joining us today. I know we've got a variety of folks we have several of our advisory board members. We have, of course, our speakers. We have attendees who are clinicians in a variety of backgrounds and fields. And I thank you all for joining us. Again, we are being flexible during 2020 and moving to a new format. So thank you for bearing with us. 2020 has certainly thrown some curves, and we're having to do things in new ways. Yeah, Toya is also getting IT calls. And again, if you hopefully you've seen the chat. You can put your questions in there. If you have questions for our speakers, please use that chat. With this many people, virtual etiquette, we're going to ask that people keep their mics off and keep yourselves muted so that our speakers can, sorry, I'm distracted while I'm helping folks enter the room. But again, if you have questions there, you can post them there, and Toya is helping me monitor so that we can be sure and point those out to our attendees, to our speakers. Obviously, if you have a question, somebody else may, and we have some really pertinent topics today that are certainly timely. At this time, I'm going to pause for just a few moments while I get the slides ready for our first speaker and make sure that everybody is admitted. So this is your last chance to go to the bathroom before Mr. Williams starts speaking. It is sure to be an excellent presentation. So I will see you in just a few minutes. Okay, we've got about 5 minutes before our first presentation. Toya has put the agenda in the chat, and she will also put the CE instructions through there as well later today. Again, welcome to the 5th Annual Symposium on Mental Health Issues from Mental Health America Spartanburg and Spartanburg Regional Healthcare System. My name is Susan Lee. I'm an advisory board member of Mental Health America Spartanburg. I'm also a licensed marriage and family therapist. And our advisory board chair is Mary Miles. And our advisory board members are Vanessa Thompson, Sally Owens, Peter Moore, Nelda Hope, David Cato, Kathy Emmert, Kristen James, Jim Rentz, Mary Hope Rhodes, and Casey Sims. And we welcome you to today's event. Thank you for bearing with us as we transition into this virtual format, which is new for Mental Health America Spartanburg. We will be getting started with our first speaker of the day, Roger Williams. For those of you who don't know Mr. Williams, he is the Executive Director of Spartanburg Area Mental Health Center with the South Carolina Department of Mental Health. He received his Bachelor's of Social Work from the Rochester Institute of Technology. He received his Master's of Social Work specializing in community mental health from the University of Illinois, and he completed coursework towards a doctorate at the University of South Carolina College of Social Work. Mr. Williams is a South Carolina licensed independent social worker, clinical practice. He is a qualified mental health interpreter supervisor, holds RID and NAD interpreting certifications, and he has been recognized at the state and national level for his leadership in mental health services within the deaf community. So on behalf of Mental Health America and Spartanburg Regional Healthcare System, I invite Mr. Rogers to begin presenting. And again, just bear with me as we make that transition.
Thank you, Susan.
There you are.
Yep. Hopefully I'm here.
Yes.
Hopefully I remember to turn off mute so that I don't have that embarrassing couple of minutes where I sit there talking and have everybody wondering what I'm saying while I try to figure out why no one's answering.
Well, thank you so much for presenting, for being first up in this new format. We're all learning together. And I understand that you have some experience with virtual presentations, so I think you're a great choice to go first.
Well, I don't know that a lot of people know this, but Deaf Services in South Carolina started telemedicine here almost 25 years ago. So in the deaf community, telecommunication is the norm for us. In my home, I have 4 video phones. I have 6 children, and my wife is deaf as well. And so they spend, when my girls were, and nobody take offense to this, but this seemed to be more my girls than my boys. When my girls were teenagers, they would spend a long time on video conversations with their friends. And because of course it's a video conversation, I can observe it. And they would be sitting there saying, "What are you doing?" "Nothing." "What are you doing?" "Nothing." And I'm thinking, there's $20,000 of equipment there to have a perhaps less than the most productive conversation. So spent a little bit more time with video use, I think, than, so when of course, when the crisis hit and we had to move a lot of things over to video, our Deaf Services program was already at 100% televideo before. So they easily met the benchmark of trying to get to 50%, not a difficult stretch for us. So yeah, a little bit more used to doing video presentations, and these are the norm.
You know, I had not thought about that. Thank you for sharing that insight. You know, we sometimes think of things being done for selected populations as different in the norm, and yet here they are ahead of the ball, and we're learning from what they've been doing. So thank you for bringing that up. If you would like, I will go ahead and bring your slides up. Let's see.
There we go.
Right.
Susan and I have developed a very elaborate scheme to change slides. So hopefully it'll work and we'll be able to figure all this out. I look at the slide and I realize my email address is not up there. I will say fortunately, the department has changed over to a fairly logical email system. So if you do need to send me an email, it is just to roger.williams@SCDMH, South Carolina Department of Mental Health, scdmh.org. So I probably need to add that. For those of you who aren't familiar with the alphabet soup of the deaf community, the last bunch of letters refer to the National Association for the Deaf Interpreting Scale and the Registry of Interpreters for the Deaf Interpreting Registration. So that was up until about 2.5 years ago, I was involved in deaf services completely. And in fact, when I took this job here at Spartanburg, it was the first time I had worked with hearing people all day long, 5 days a week. And it was a little bit of an adjustment for me because I live in a deaf world. My wife is deaf, my kids are deaf, my staff were mostly deaf, and my patients were all deaf. So it was a little odd to get used to being with hearing people and figuring out all that. And I'm sure the staff here at Spartanburg area will be happy to tell you of the terrible things that I've done as I've tried to figure that out, and not always accurately. So I really appreciate everybody being here. What I really want to talk about this morning, and this is, I know 60 people may seem like a lot, but I've been doing presentations for much larger groups, so I am going to try and keep track of the chat box and keep us on track. But please feel free to ask questions, and if I don't answer it right away, hopefully we'll have a little bit of time at the end to ask some of those questions, and then move on from there. And if we don't get to it by right towards the end, and I'll just let you know we're out of time, please feel free to email me those questions and we'll try to answer them individually. I want to talk about, just kind of maybe lay the ground for some of the other presentations for the rest of the day. What exactly has the pandemic, and perhaps equally, if not more important, the pandemic response meant to those of us in community mental health? What have we done? How have we responded? What are we seeing currently? And then I think I want to spend a little bit of time talking about what do we see moving forward? What kind of impacts do we anticipate on? And I, of course, I'm going to take it from the perspective of the mental health center, but clearly those same dynamics are involved in any of the other mental health providers in the community, because we're all dealing with very much the same type of things. Officially, I need to declare I have nothing to disclose, which always sounds like a rather strange sentence, but that's what they're telling me to say. So I have no secrets. And if I do have secrets, they don't have anything that's got anything to do with anything that I'm not supposed to be saying at meetings like this. So going from there, let's kind of just start with, and the information that you're going to see on these slides is garnered from several different resources. There is a list of references at the end, but most of it comes from the CDC and the Census Bureau. A lot of folks don't realize, I think when we talk about the census, people think of the census, the one thing every 10 years. No, I'm not going to get into the politics of it, but the one thing every 10 years where we count everybody. Well, that's only one part of what the census does. They also do a thing called the pulse surveys, where it's more of a quality of life issue, and they're very current data. We had stuff that they put out just from 2 weeks ago, and it also is a little bit more localized than the generic census data. So some of the information comes from them, some of it comes from CDC and what's called the MMWR, the Morbidity and Mortality Weekly Review. Gruesome title, but they provide a lot of information about what's going on with different events in the community. There's also some other resources that you'll see later on, and again, there's a reference list at the end. So one of the first things that we want to look at is just how has what is the impact of the coronavirus, and most of these can't really separate out what's the impact of the virus itself and what's the impact of the lockdown and the restrictions. And so really, for the purposes of this conversation, those two are kind of one and the same event. We will talk a little bit about some of the impact specifically of the virus as we move forward and as we look forward. But for right now, we're looking at the impact not just of the disease itself, but the pandemic and the response. So obviously, a lot of concern from the substance abuse side, and the good folks at the Forrester Center, of course, that's really their cup of tea. But as anybody who works in mental health knows, when you are working with individuals who have a mental illness, there's also a high correlation with some type of substance abuse. And what we're seeing is that almost 20%, and what's kind of important about these numbers is look at the age range that you see in these groups. You know, normally when you look at impacts of mental health, 25 to 44 is not normally the riskiest group. Typically, we see it either in younger people or in senior citizens, but clearly what you see is that 25 to 44, those sort of, you know, working age, and I think a lot of this is the strain that this is placing on parents. I am not in the 25 to 44 age group. I'm just on the line there over between I'm colorblind, as those of you who know me know. I'm going to guess it's kind of an orange and a dark blue, and if it's green, I apologize. But in that 45 to 64, just barely in that age group. So, but normally that's the group that we often have some of those concerns about isolation and depression. But what we're seeing is that 25 to 44 age group, almost 20% report starting or increasing substance abuse. When we look at considered suicide, you know, a stunning number as a response to the pandemic, you know, was about 16.5% reported considering suicide in that age group. Obviously not to be sneezed at is the fact that 9% of young adults 18 to 24 also considered suicide. But when we look at adverse mental health symptoms, and most of these are anxiety and depression, we see, you know, well over 50%. And again, we see the most impact on the 25 to 44 age group, which is just not an age group that we typically associate with increased stress, increased negative response to events. This is, as a grandparent, I no longer have children of school age living in, well, it's not fair, it's not true to say I have no longer have them living in my home, but they're not my children, they're my grandchildren. So I have a 5, a 6, and a 6-month-old living in my house. Through the wonders of the pandemic, I had family members who had to return home, and they brought their children with them. I guess it was probably better than leaving them in their house by themselves. So I see firsthand some of what parents are going through as we try to navigate all of the stressors associated with the multiple different school arrangements. We have kids who are going to 2 days, 3 days, kids who are staying home, kids who are being more homeschooled. I see a couple of folks from, I'm going to pick on Janet just because I see her, she's right on my home screen, and Courtney, both who are working in schools and certainly can speak to that more effectively. But I think when we look at that 25 to 44 age group, we're seeing the impact of those stressors on that group. So that's sort of a global look at just what does the first set of numbers look at. But I also wanted to break it out not just by age, which of course is important, but let's also look at it by racial identity. So when we look at that, in the same way that we saw a disproportionate impact on age, we also see a disproportionate effect by race. And this is perhaps, sadly, perhaps a little less surprising than the way it broke down by age, in that we see pretty consistently across the board that folks who are Black or identify as African American, and particularly concerning is the really high number of individuals who identify themselves as Hispanic, who are reporting an increase again, and it's pretty consistent across the board. It isn't in one particular, it's both an increase in substance abuse, an increase in suicide, and an increase just in mental health symptoms as a whole. So we see that impact disproportionately across racial identities, and that then has some real implications for us in mental health as we look at how do we meet those needs, and recognizing that meeting the needs of one group may or may not meet the needs of another. So it's important that we understand that it, even though, as everybody has heard people say many times, the virus does not care any of those above factors. It's a virus. It doesn't know who you are, doesn't care who you are. But the impact, because of the economics and the existing health disparities and economic disparities, multiply and magnify the effect of the pandemic on certain populations. So just something that we're going to keep in mind as we go forward and we talk about the different impacts that we see in different groups. And it almost looks like Susan and I know what we're doing with the advancing of slides. So thank you, Susan, for being so on top of that there. It seems to be working. So let's first look at the amount of time somebody feels down, feels depressed, feels hopeless. So, about half the population said not at all, that they aren't. But 30% of people report feeling depressed, hopeless, or down several days. And this is several days a week when the way the question gets worded, and this is from the census data. Several days a week, people report that. And then 7% and almost 10% report that almost every day. And again, the way the question was worded, they were specifically looking at what was the impact of the pandemic on that mood and that emotional status. So we see that people are feeling, and I will point out, this is specifically to South Carolina. This is South Carolina data. This is not nationwide. One of the census reports does break it down by South Carolina information. So this is right here at home. This is not just somewhere else in the country. And so pretty disturbing when we start talking about what is the impact and what are we seeing in terms of a community mental health. And again, this is a little bit confusing to read. So what I would, again, this is South Carolina. So this is, when you see 400,000 people, that's 400,000 South Carolinians. So this is based on the pulse data from the census, which has some very specific things. They are not yet releasing it at the county level, and I don't know if they're going to, just because you start to get into being able to identify individual zip codes, and so it's not yet available that granular, but we can see that across South Carolina, and what I want you to look at is that this, and if it's not light blue, somebody tell me, I'm pretty sure it's light blue, number that not reporting, not as a percentage of the overall total. So what you see is that the nearly everyday percentage is highest for that 30 to 39 group. So again, we're seeing that the stress of dealing with the pandemic, and again, I don't mean to single out kids. I love kids. I have 6 of my own, but you know, that the stress of dealing with that group, I think, contributes a lot to this finding that a very large percentage of people in what is normally a pretty healthy emotional age of 30 to 39 are reporting being depressed. And you know, it is interesting when you look at these larger, the older groups, the 60 to 69 group, yeah, that's the group I'm in, the 60 to 69 group are reporting a smaller percentage of nearly every day being depressed. And even in the 70 to 79 group, it shrinks to the smallest percentage of the overall population. So an interesting perspective on who is really feeling the impact of the virus and our response to it. So when we look at what kind of symptoms are people reporting mostly, and again, I do want to say this is state-specific data. The you know, what we see is that now, I'm sorry, I apologize. The impact, the symptom description is from the CDC MMWR reports. The sleep disturbance is the #1 symptom. And I have to tell you at a personal level that's the one that impacts me the most. I cannot tell you how many sleepless nights I've had that I could pretty clearly track to some of the challenges that we're experiencing either in dealing with the pandemic or some of the racial unrest and strife that's been going on. The sleeplessness is certainly the one that gets me. I can't tell if I feel relieved to know I'm in the majority or not, but that clearly is the symptom that most people are having. And then second, of course, is eating difficulties, people not eating or perhaps eating too much. We all know stories of people who have a hard time, and Ben and Jerry's pint goes pretty quickly. So I think everybody responds differently to that stress. And as I said, I know for me it's sleep, but for many people it's eating. But it's not, the headaches are not an inconsiderable amount, and temper. You know, even at the workplace, we have talked about just everybody being perhaps a little bit more on edge than we might like or is their norm. So we have even talked about in the workplace, working with staff, and hopefully those folks who are working at the mental health center are in generally pretty good mental health, but we certainly see that stress showing up in work relationships and in, so, you know, we've all cautioned all of us to give everybody maybe an extra couple of seconds of grace when we're dealing with folks, because we clearly see that sort of just temper and being on edge is a little bit more an issue across the board. So what did that mean to the mental health center when the pandemic started? What did we do in response to that? Well, you know, the big one was, of course, we changed from in-person services for the vast majority of our services to some type of telehealth. I have to say, I hope my IT person is not listening in on this conversation, because before the pandemic, we were told there was no way we had the technology, the bandwidth, the infrastructure to support telehealth. You know, when we would push for it, we would get, no, you know, there's no structure that, you know, we just can't do it. And inside of 1 or 2 weeks, thanks to the hard work of those same IT people who were saying, can't do it, okay, we got it done. So, you know, we had to train staff who, like any large workplace, you know, we have 160, 170 staff. We have some staff who are extremely technically proficient and very comfortable with computers and technology and cameras and microphones. And we have some staff who are still trying to figure out, what does that on-off button do exactly, and keep pointing to the monitor and calling it a computer. And they perhaps struggled a little bit with figuring out how to do telehealth. And of course, if our staff were experiencing that trouble, so were so many of our patients. And our patients span that same continuum of challenge in how do you use technology. We have patients who have got the newest smartphone and they just hit the button and they're ready to go. And we have patients who still have dial-up push button. I don't think we've got anybody who's still got a party line phone, but we do certainly have patients who are still learning how to use even pretty basic technology. And this whole telehealth environment was very new. But those were changes that we had no choice. We had to make when we had to figure out a way to see our patients. And so the big thing was, and of course, we couldn't have done that, at least not in any sustainable manner, without support from policy and insurance companies. And I hate to say this, but the decision by the insurance company to allow, or the insurance companies, Medicaid, Medicare, all of the private insurers, the decision at their level to allow us to bill for services made a world of difference, because instead of, that's half our income to 2/3 of our income, depending on the program. And if we weren't able to get the revenue from those fee for services, we would really have been in much worse shape than we were. So we are all hoping that moving forward, those changes will become permanent and we'll be able to continue to provide some level of telemedicine in the future. And we'll talk about that in a couple of slides. So changing to televideo, telehealth, and I'm kind of making that distinction because we are also providing services by telephone for some of our patients where the technology just is either inaccessible because they don't have, some sort of broadband internet service, or they don't have free Wi-Fi on their phone, or whatever, if they've got bandwidth issues or capacity issues, or just plain don't have access to the technology. We also do provide services by telephone. We had purchased an RV that arrived the first week, maybe the last week of February, I think, actually, the last week of February. We had planned to kind of hold on to it and do some work on and get it ready to go and make it into a mobile clinic to serve some of our smaller communities. And well, that didn't happen. What happened was that first, when things hit, which for us was around March 13th, the RV was put into service to go out and serve primarily our community residential care facilities, our patients who could not come out of the home but needed things like injections. We do not yet have a way to do an injection by telehealth. We've talked to the nurses and they all suggest that they cannot give a shot with a 3-mile needle, nor do I really think I want them to be. So they have been going out in the RV with clinical staff and providing. So even though we hadn't anticipated putting an RV and putting it into service, or the timing was wonderful. So that was something we were able to do, and we've been continuing to do that since those first couple of weeks in March. Staff working from home. This was another thing that, over the years, staff have said, we need to be able to work from home. And our answer was, and I certainly was one of the people giving that answer, no, can't do it. The technology's not there. We're not sure we have some staff where, how do we make sure they're doing what we need them to be doing? And there were concerns about confidentiality and concerns about managing their children in the home while they're working and all of those fun things. And quite frankly, we had to kind of go, all right, well, it's a new day. So we had to come up with new policies and new procedures and new mechanisms. And I'll show you some numbers about just how many of our staff ended up working from home in those first couple of weeks. But we had to do that to try to do what we could to prevent the spread of the pandemic to, obviously not to our patients, but also to our staff. And while our commitment is always to patients first, it's a recognition that if our staff are sick, we don't serve our patients. So the health of our staff has to be our top priority to make sure that they're then able to serve as essential healthcare workers, they're able to then serve all of the patients that we're reaching. So we did still have some patients who got injections at the clinic because they couldn't come in, they couldn't set up a time. So we had to, if you've been by the clinic in the last couple of months, what used to be one of our side entrances has been turned into sort of a mobile drive-through shot clinic. So you can drive through, the nurse will come out to your car and give you a shot. I guess it's a good thing that for those of you who are my age, you might remember shots were given in a location on the body that you might not want to be given out in the parking lot. But most of the medications have been changed, so they're being given up in the arm as opposed to, well, we'll just leave it at other parts of the body. Let's just say there. So that change is it is something that actually helped out. So even though obviously they didn't make that change to make it easier to give shots in a pandemic, it had the effect of making it easier so we can go up to a car and give a shot in the arm. And then we had to look at expanding our crisis services. And one of the first things was we now have 4 full-time staff on our mobile crisis unit who are going out with law enforcement and EMS to respond to mental health crises in the community. And that obviously, like all of our services, is not just in Spartanburg County, but also in Cherokee and Union. So those are all changes. Some of those changes were changes we were planning on making. Some of those changes were changes that we ended up having to make a whole lot faster than we had planned. So there really wasn't much that we said we never ever wanted to do. They were things we thought we might do in 5 years, and all of a sudden we had to do them in 5 minutes. So this slide that you're looking at right now really just reflects, the end of March. We were trying to figure out, as I think anybody who was working at the mental health center I know during that time period got pretty frustrated with me, because I would send out an email identifying a policy and what we were going to do, and an hour and a half, 2 hours later, I was sending out an email saying, ignore that first email. We're now on the second email, and by the end of the day, sometimes that was 2 or 3 180 returns, and everybody was getting a little bit dizzy. As new information was coming out, and in the first couple of weeks, it was coming out very quickly and sometimes quite contradictory as we tried to figure out, how do we restrict access, who goes home, who stays, who can, who can't. There were lots of conversations. So we ended up with under 40% of our staff being in the building, which was a number that if you had asked me before this graph started, when the number was, if you'd asked me the 13th of March, what percentage of staff could we survive with in the building, I would certainly have said we need more than half of our staff. But we got down to around 40%, and that is staff. When we say in the office, it doesn't necessarily mean in the office. For example, our folks who work in the jail, they still have to go into the jail because, as you can well imagine, the persons in the jail don't have easy access to, they certainly can't go out, and they certainly can't come here. So our staff working in the jail, we're still working in the jail. The schools, many of them, of course, had to close at this time, so our staff were then working not in the school, but working at home and seeing patients from there. But we have patients who are emergency staff, our crisis staff, our nursing staff, some of our physician staff, all of those had to be in the clinic. So we got that down to about 40%, and that was really the low. That was a pretty significant chunk of challenges when we got to that kind of numbers. And so, as you can see, that has slowly crept up. Right now, the number of staff who are working. I see that the slide has got number of visits. That is not the right description for this slide. It should have said the number of staff. It's amazing how many times you can look at a slide and proofread it and still get it wrong. So, what is kind of important to note is 2 things that I would point out. One, even though we have 160 staff, we have an awful lot of staff who are on leave. Some of them on leave for things that have nothing to do with the pandemic. We had a reduction in just the number of staff working. We've had several staff who have left for, and some of them were kind of the routine people are retiring. But we also had some staff who were thinking about retiring in the next couple of years and decide, well, this is the next couple of years. If, concerns for their health, concerns from their family. So for a lot of reasons, for some of our younger staff, trying to juggle school and home and childcare meant that we've also had, and this is not just here at Spartanburg, but this is across the state at all the mental health centers, we've seen a higher, larger turnover than is normal for us. And so you're seeing that sort of some just loss of, we don't have as many staff here as we did when all of this started. We are continuing to recruit and hire, but it is still kind of a little bit of an uphill battle. So that is important to see, that it isn't just that we now have more staff working, in the building, or at a school, for example. The schools, when they brought the students back into the building, asked us to have our staff back in the building. Of course, it made sense. So we have staff there. So when we say in the office, it doesn't necessarily mean in this building. It just means they're in a work site, not working from home. So right now, about 20% of our staff are working working at home still, but the remaining staff are working in some site, whether it be the emergency room, a classroom, a jail, or here in the office. And then, so as I said, we went from what telehealth to this kind of telehealth. So as you can see, in the week before all of this started, the vast majority of our services were in person. We've always offered some telehealth, primarily for psychiatrists and psychiatric appointments. We have psychiatrists. There is now a psychiatry residency program in Greer, but they're not even graduating their first students for another couple of years. So we have relied on psychiatrists coming from Charleston. Well, they're not going to drive up here every day. So we have been seeing roughly about 10% of our patients by some form of telepsychiatry before all of this started. But what you can see is this bright blue, what we call COVID telehealth services, had a significant, this is where we went to almost half of our services were provided by some form of telehealth video. And when you add telephone in, you can see it's almost 75% of our services in the first couple of months were being done by either telephone or telehealth. The community telehealth, just to sort of explain that kind of odd definition, community telehealth is the telehealth that was being done before COVID. So this was with the doctors, say, coming from Charleston. So the big change was from the insurance companies to allow us to bill for more services than just psychiatry, and allow us to provide counseling, therapy, nursing services, not injections, of course, but other types of services by telephone or telehealth. And as you can see, this continues to be a pretty sizable, it's about half of our services are now being done face-to-face, as opposed to, if you compare the number being done by telehealth now in the last couple of weeks, as opposed to where we were before COVID, you can see how big a difference that's made to our service delivery. So where we are right now, as I said, about 50% of all of our services are being done in the building. You saw from the previous slide that the 50% that are being done by telehealth, about 25% are being done by telephone, just call up somebody and talk to them. And then about 25% are being done by video. We are pushing to increase the percentage of services that are being done by telephone, excuse me, other way around. We're pushing to increase the number of services being done by televideo as opposed to telephone. And really that's for two reasons. One, clinically, we think it's a lot better if you can see the patient than if you just are talking to them by the phone. And then a somewhat more pragmatic concern is that we're also anticipating that funding and insurance companies are going to change once things get over. Do not ask me when that's going to be. If I knew, I would certainly tell you, but I can certainly tell you I do not know. But when things do settle down, we anticipate that insurance companies, we're hopeful that they will continue to provide support for televideo services, but we don't expect them to provide support for telephone other than certain assessments and contacts and crisis services. So our goal is to get to 80% or more being done by televideo as opposed by telephone. But, you know, at least for the duration of the pandemic, we're kind of expecting about 50-50 between telehealth services and in-person services. So the building is open to patients who want to come in, who want to be seen, either because that's a preference or because they don't have the technology at their home or the technical competence, which is part of that technology. It doesn't do you much good to have a state-of-the-art machine if you can't find the on-off button. So, you know, we're working, so about half our patients are coming in, and about half of them are being seen, you know, as I said, at the schools, of course, they're being seen in person at the school. The jail is being seen on site at the jail. But for that other half, so people are coming into the clinic. I will tell you, if any of you have come into the clinic in the last 6 months, you've discovered a very different setting. You don't go in through whichever door you want. You have to all come in through one door. You get the lovely questions that we all know the answers to so well. Have you been around anybody who's been exposed? Do you have any symptoms? And I don't know about you, I've had my temperature taken. I had my temperature taken 4 times yesterday because I had to be at another clinic and then I had to be at a hospital. And I've had my temperature taken more times in the last month than I think I had in my entire lifetime up until March of this year. So I now know how much my temperature goes up and down every day. A wonderfully useful but somewhat trivial piece of information. So that's what's going to happen if you're going to come into the building. But it is going to be everybody comes in through that one gate, and quite frankly, we're trying to figure out what are we going to do exactly as it gets colder. When I moved to the States, I'm not originally from the United States. When I moved to the States, I moved to Rochester, New York, and went to college in a place that got 4 foot of snow and sub-zero weather on a regular day. So I do wonder about the definition of winter in this part of the country, but it's still a little bit cold to be sitting out on the front lobby, on the front steps when it's 20 or 30 degrees. And so we're trying to figure out how do we accommodate that within, because it's getting pretty busy. It's not atypical to see 10 or more patients trying to come in through that bottleneck of check-in and make sure they're safe. And we've been keeping them outside because we obviously want to reduce the potential for infection. But how are we going to do that? And we're still trying to figure out how we're going to do that as it gets colder. The RV is still busy driving around different parts of Spartanburg County, and our staff are continuing to work in the schools and the emergency departments and in the jails as we move forward. So when we start talking about what services we have available and how are we meeting those needs, one of the big things that we put into place is a thing called the SC Hopes Line. The state of South Carolina, we applied for money from SAMHSA and FEMA and a collection of other alphabet-souped agencies. And so we have worked to make sure that we can provide information about the pandemic and how to respond to the pandemic. So we staff the SC Hopes Line for the state of South Carolina, along with one other mental health center closer to the coast. I'm going to give you the phone number as opposed to the abbreviation phone number. And then I'll have a slide at the end with all of that information. And it hopefully that made the transition over. But if not, it's SCE 1-844-724-6737. So that's if you just dial out SC Hopes. So that line is available. It's staffed. There's somebody who answers the phone after hours. It rolls to one of the crisis services, but from 8 in the morning to 8 at night, it's staffed here. And we have staff who answer that phone and can provide information about what resources are available, make connections with mental health services as needed, all that kind of fun stuff. So, so we staff that for the entire state. We also, as part of that process, we provide services to particular specialty populations. So if you call in, we'll make a referral as needed. And again, there's no charge for the calling in and making the appointment. Obviously, if there's charges for the services, but that's different. But the SC Hopes line is free and available to everybody. Let me get the slide to change over. So the focus is on that family who just doesn't know what to do and how to cope. So it's trying to provide a quick, easy access to all kinds of levels of mental health services, all the way from just, where's a testing site, to how do I get my kid to pay attention to their classwork, or how do I, how am I supposed to go to work, or when should I go get tested, or how do I know what's the guidance from the CDC or whatever. So we try to keep track of all that kind of fun stuff on there. The next piece of that is we have it's called the HOTS group, the Hospital Outreach Team. We have a group of folks that is being sponsored by one of the other mental health centers, but that you access through the Hopes line. So the HOT team can work with staff who are working in healthcare or in hospitals or even in doctors' offices who have particular issues dealing with the very emotional stress and strain that this time is providing. The department also operates one internally just for DMH staff, because this is obviously a stress for everybody. I'd love to think that somehow we were unique and not going to be subject to the same stress that everybody else is feeling, but that is obviously not true. So we have the healthcare team, and again, access the same way. You call the SC Hopes line, they'll make a referral to the healthcare outreach team, and they can provide that support to healthcare workers across the system. Kind of the last one that I'm really excited about is called Tu Apoyo. For those of you who don't speak Spanish, that means your support. And this really grew out of the advocacy of one of our Hispanic staff members, somebody who's a native speaker of Spanish, who felt that the community needed people who were answering the phone in Spanish. So we're the only center who staffs this one, but we also have a statewide service for Spanish speakers. We have 5 either native or very fluent speakers of Spanish who are working here. Let me just give you the phone number again. This number is different, obviously. It's 1-833-882-7696. But that is available to anybody who speaks Spanish, and we make sure that they have access to those services in the same way that English language users have. And we're pretty excited about that. And in fact, it's got a lot of press, not just here in South Carolina, not even just nationally, but the Mexican consul came to do a special session and to bring that information out to the rest of across the Spanish-speaking countries. So pretty excited about the Tu Apoyo line. So what are we seeing in terms of all those numbers and how we're being impacted? We are seeing an increase in patients. This is the number of new patients per day that we're getting into our system. And you can see back in the beginning of March, that number was a little bit below 40, and now it's almost to 50 patients a day. So it's pretty busy at our intake department. You know, I want to say to everybody, come one, come all. I suspect my intake workers are probably going, no, Roger, stop talking quickly before you say something we're going to regret. So, you know, we definitely are seeing an increase in the people being referred for service, which is good because we know that need is out there. All of the earlier slides when we looked at the impact of the pandemic told us we should be seeing more patients, and so we're kind of glad we're seeing more patients. What we're seeing in the number of services is also going up. This is the number of the and I realize it does not distinguish between this is child and adult, and I don't know what happened to the little legend that was supposed to be on the slide. Obviously my fault, and I apologize for that. But what we've been seeing over the summer, we actually had an increase in the number of family therapy sessions from last summer. So for all of the bad things that the pandemic and COVID has done, we are seeing an increase in family intervention, because when we're reaching out to the home to do a televideo, whether it by video or by telephone, the family is there because, let's face it, like all of us, they didn't go anywhere. So we are seeing more opportunities for family therapy and more opportunities for our staff to reach out to kids and families, which is just wonderful, because that's always a group that we struggle to try to get out to families. So we were really excited to see an increase in family therapy. Now, what of course kind of went off the cliff was the number of group services, because we just have not found a safe way to do groups except in some fairly limited situations. One of our staff actually does groups outside in a field with everybody sitting far apart. We've received some very, very limited approval to try to do some groups by video. Some of the regulations are a little bit fuzzy and concern about confidentiality, because, you know, if I'm in a group in a room and I'm telling you my deepest, darkest secret, I know that that's everybody in the room. But if I'm in a video setting, I don't know who's off screen. I see a couple of you on screen. For all I know, your significant other, your work partner is off that screen and listening in on the conversation. So we haven't quite figured out how to provide the same level of confidentiality and trust in a video setting by group. So group settings have gone down, but family settings have gone up. So that's kind of exciting to me that at least there is a little bit of a silver lining there. So what do we see moving forward? As time goes on, we expect that probably 25% of our services, when all of this is over, about 25% of our services will continue to be by telehealth. And that's up from a little bit less than 10% before this came on. So we're going to see some patients who transportation is a huge barrier. Sometimes there are some patients who are actually more comfortable not coming into the clinic. A group setting for some people, for some illnesses, that group setting itself, the coming into the clinic and all the hustle and bustle can be distracting or distressing. So we expect about 25% of that. As I said, our goal is to get to 100% of televideo. That's probably not realistic, but so it may be about 80% of that being done by telehealth or televideo, some kind of video connection. And we use every platform you can imagine, Zoom and Doxy and Doximity and Teams and all of these things that we've become familiar with, that if you'd asked me a year ago, I wouldn't have known what they meant. Some of that, you know, I mentioned the insurance company had made some provision for video services and billing for video services. There were also changes to the enforcement activities under HIPAA, the Health Information Portability and Accountability Act. Some of those changes allowed us to, I know better. Health Insurance Portability and Accountability Act, not Health Information, Health Insurance Portability and Accountability Act. But some of the privacy restrictions, they didn't actually change the laws because for a complicated set of reasons, you can't change the laws that fast, but they changed the enforcement activities. So we were able to do things like over regular Zoom as opposed to medical Zoom. They provided some outs for that. So we see some kids using Google because many of the schools are using a Google platform. So we had Google Duo and Google Hangouts and other ways that we were seeing kids that were being permitted. Some of those probably are going to go away when they put some of the rules back in, or put the enforcement rules back into place. Our RV is going to transfer from serving the CRCFs and reaching out and providing those injections to what we originally wanted it to be, which was reaching out to the smaller communities like Blacksburg or Boiling Springs or Jonesville, Woodruff, going out to some of those communities and providing a mobile clinic, which is really our goal and what we had originally intended. And then, of course, the pandemic took the plans. But then we also, and I mentioned that I was going to talk about this a little bit, what is the long-term impact of this pandemic? The mental health, you know, when the pandemic is over and said and done, and I know all of us can't wait for that day to happen. Unfortunately, I don't have the day when that will happen. But what we do know is that there are going to be impacts that we're going to see in mental health for a significant period of time. And some of those are going to be, we are seeing that for some patients who have had COVID and have recovered from COVID, they talk about a COVID fog. They talk about some cognitive declines. They talk about some very real impacts on cognitive functioning and ability to think clearly. And now, of course, we don't know. Are those going to last a week, a month, a year? We don't have anybody who's a year past having COVID because we haven't had it for a year. So we don't know how long that's going to last, but we do know that it's a very real thing. And we see increasing levels of depression in individuals whose other life things seem to be doing okay. So it doesn't seem related to just the stress of the pandemic, but it does seem to be related to it. The COVID, the bug itself seems to be causing some damage in those areas. But as you can well imagine, the research is very, very just starting out. And so we don't really know how much that will be. Obviously, there are 216,000 people who have died in the country, and their families are here, and so we'll be dealing with the families of those who died and the families of those who perhaps have also experienced some significant lasting physical side effects. So that's, you know, it's what is it now, the third leading cause of death in South Carolina. So we know that's going to be an issue that we're going to be dealing with, grief, both complicated and uncomplicated. And the reality is that for many of these families, unlike some other forms of death where you were sort of given a lot of notice and it was not unexpected. So there were families of, you know, younger people who died who didn't have any preparation, expectation, anticipation. And of course, that's going to have its own negative effect on somebody's mental health. Children, students at schools, we just don't know yet, but we anticipate that this is going, you know, the isolation for those kids who stayed home for 2 or 3 or 4 other months. I know the folks at the school are all too well aware, not just of the academic impact that has on a child, but also on the social emotional development. And a 6-year-old still becomes 7 in a year, whether they develop the social skills they needed at 6 or not. Their body and their emotional growth doesn't stop, but perhaps some of the learning lessons they should have learned. So we anticipate seeing greater challenges in students and children as time moves on. And then, of course, just in the general public, not just the economics, because we all certainly know that economics and an economic downturn has negative impacts on people. And so we're going to be seeing that in the general public as well, and that increased stress and anxiety that we see from the economic impact and the social impact of the isolation, and why we so often tell people maintain those social contacts. And lastly, just I don't want to ignore the impact that this has on our staff. And of course, not just ours, but the good folks who are working over at Spartanburg Regional Healthcare, all of those working in EMS or in other first responders, in doctors' offices, in DHAC, and all of the other essential health workers. What we're seeing is, as you can see on this slide, and this, interestingly enough, this was drawn from, in case you wonder, how do we get this information so quickly? This research is actually out of China and looking at the impact on the healthcare workers there, who obviously are months ahead of us. And again, I'm not saying good, bad, just their pandemic struck that much earlier than ours. And as you can see, almost 70% of healthcare workers experience some symptoms of PTSD. Now, those are fairly mild, but still 35% rating those symptoms as severe is a huge percentage. So we are very concerned about the impact on our staff and how they're dealing with the pandemic. And again, not so much the virus itself, but the stress. I have, there's no secret, people who know me know this, I have a compromised immune system, and I am putting myself at risk by coming to work, because I think it's important to be here to serve our patients. But that also adds to your stress and strain, and so we're seeing increased levels of depression and anxiety, and as you already know from my self-disclosure, increased risks of insomnia. So all of those things together are something that we need to be thinking of moving forward, and as we prepare for the day, hopefully not years and years away, but months and months away. We are, just sort of to give you an idea of where we're thinking in terms of time frame, we're anticipating that we will still be kind of in this lockdown, restricted access mode, probably through March, April, May of next year. So, we will do everything we can to be open as much as we can and to serve the community as best we can. But we anticipate that we'll be dealing with many of these things for some time. So, if I have done my timing correctly, here's the wonderful references. We have just a couple of minutes. And if there are questions that people want to put up in the chat box, please feel free to do so. And if not, I really want to thank all of you for paying attention. I hope all of you managed to stay awake this early in the morning, and that now I have set a very low bar so our later presenters can demonstrate their wonderful competence and skill, and then you'll go, yeah, well, that first one, not so much, but the rest of the afternoon was really good. So I hope I've accomplished the goals that Susan wanted me to accomplish. And I also want to express my appreciation to Mental Health America and to the Spartanburg Regional Healthcare System for allowing me to come and speak. And hope I've answered at least some of the questions you might have about that. Susan.
Yes, Roger, thank you so much. I don't think that you set the bar low at all. I learned a lot from your presentation, beginning with as you said, the deaf community leading the way with these virtual platforms. And I appreciated your review of the fewer staff, the greater demands, and the more diverse ways of meeting the needs of the community. The statistics were phenomenal. I'm surprised and stunned that if I heard you correctly, and can you confirm, COVID being the third leading cause of death in South Carolina right now? Does that sound right?
I think I may have, what I meant to say, and I may not have been absolutely clear, is that is, according to the epidemiologists and all of that, it is on track to be the third leading cause. I think right now, that's always a little bit of I think it's like 4th or 5th, but they're anticipating, sadly, they're anticipating continued deaths through the end of the year, and that their anticipation is that by the end of the year, it'll be the 3rd leading cause.
Okay, okay, thank you. Thank you for clarifying. I just hadn't put it in context with other death rates. I hadn't looked at that information. I tend to look at what's going on with COVID separate from all other health issues. So you're just talking about weaving all of that together, and that is a moving piece as COVID comes in kind of waves. I don't see any questions in the chat. I see lots of thank yous. And I do appreciate you giving us your time and your expertise. And I appreciate your sharing about the changes that DMH or Spartanburg Area Mental Health is making. We have a comment. Thanks so much for the SC Hopes line, as well as service lines for deaf and Spanish speaking patients. Thanks for all you do for our community. So that was in the chat. So thank you so much, Roger. At this time, we're going to take about a 10-minute break before our next presentation. And I'm going to mute everybody and put slides back up, and everybody is encouraged to get up and stretch. You know, sitting is the new smoking, I've heard. So get up, stretch, go to the bathroom, get your coffee, and then we'll meet back here at 10:10. Thank you, Roger.
Thank you again.
Hello, and I'd like to welcome everyone back for our second presentation of today's 5th Annual Mental Health Symposium, brought to you by Mental Health America Spartanburg and Spartanburg Regional Healthcare System. We had a wonderful opening presentation by Roger Williams on the SARS-CoV-2, a community mental health perspective. And we are joined now by Lori Bishop for her presentation on the role of sexual wellness in addressing mental health. Lori is a native of Spartanburg and graduated from Converse College. She recently completed a sexual health certificate program, sexuality education track at the University of Michigan, Ann Arbor. She is an ASECT certified sexuality educator. I know we have lots of initials we throw around in our field, and for those of you who aren't familiar with ASECT, it is American Association of Sexuality Educators, Counselors, and Therapists. Lori has worked as the HIV prevention coordinator for Piedmont Care since 2016. So at this time, I would like to welcome Lori and turn the presentation over to her. Hi, Lori. Bear with me, Lori, while I make an adjustment. We'll all just, let's see. Okay, Lori, can you unmute yourself now?
I did. Can you hear me?
Yes, and I'm going to
Okay.
pull up your presentation while you introduce yourself.
Okay, you know, it's not a real Zoom call until someone asks, can you hear me? So if you have any issues hearing me, just let me know. But thank you for the introduction, Susan. Thank you, Roger, for being the sacrificial lamb, for being the first presenter. So hopefully I can follow he did not set the bar low. He set the bar very high. So hopefully I can follow well in his footsteps here. But I do have a ton of notes here. This is a new virtual reality that we are navigating. So just bear with me, just like we're bearing with Susan and everyone. But she gave you a little bit of my background. I will be speaking with you today on the role of sexual wellness when addressing mental health. I have no conflicts of interest to disclose. And I'm sorry, Susan, just like I said, we're gonna bear with each other. Let me make sure that I can let you know when to advance slides.
Well,
okay, so we have that. I have no conflicts of interest to disclose. And a little bit about me. As Susan said, I am the HIV prevention coordinator at Piedmont Care, and Piedmont Care is a nonprofit that provides HIV/AIDS care, prevention, and advocacy in Spartanburg, Cherokee, and Union counties, and an ASECT certified sexuality educator. And again, that is not, in my experience, very well known in a lot of fields. So just to reiterate, that is the American Association of Sexuality Educators, Counselors, and Therapists. And our, excuse me, our objective today, we're just going to be redefining some terms to not only add to our knowledge, but also begin to challenge biases and preconceived notions surrounding sex. We're going to achieve that by using visual tools to delineate the commonalities between sexual health and mental health, and also to assist in reframing how we think about sex and sexuality. And moving right along. So this is a meme that I made. There are several iterations of this. I've seen it as a nurse. I've seen it addressing social workers, things like that. But this one is specific to me as a sexuality educator. and it's what society, it's what I do. So it's, you know, like what your profession is and how other people perceive it. So we'll begin top left. So what society thinks I do, we see a very hypersexual dominatrix character. Then what my mom thinks I do. Let's talk about condoms, which that is only a small portion of what I do. And what my friends think I do. We have a person working in, I guess, a condom factory, making sure that their condoms are of the highest quality. And what I think I do, we have, I may be aging myself here, but we have Dr. Ruth Westheimer. She is a legendary sex therapist. And again, I'm not a sex therapist, but I'm a sexuality educator. And then what I actually do. So you see sex education resources, and I apologize, some of these, the writing is a little small, but for some of these you can see, I meant for some of the slides, you can see the words that are surrounding that term, sex education resources, and you may have already, that may be your go-to if someone asked you what you would think when you were asked, you know, what is in relation to sex education. So sexting, pregnancy, puberty, things like that. But for me, the words that stick out are information, research, empowerment, body image, values. So those are all things that people do not necessarily, excuse me, think of when they think about sexuality education. So all joking aside, this was all in good fun, but these are good resources, a good segue into challenging what we think about sexuality and thinking about what types of messaging we have received around it, especially with our little character up there in the top left. So just a little bit of comic relief. And this is interactive, so if you're comfortable, you can use the chat box function. If you're not comfortable, that's completely fine. You can make some notes and maybe that information will be helpful to you. Or if you just want to use this as a time for self-reflection. So we see some questions here, and I'll go through each of them. So number one, what do you think of, and you don't have to specifically define it, but what comes to mind when you hear the word sexuality? So I'll just take a moment and see if anyone has any responses to that. And there is no right or wrong. So again, this is just a starting point for us to maybe identify gaps in knowledge and take a closer look to what may have informed that. Okay, Susan said first thought is connected to gender. And then number two, what comes to mind? So you can just think about this as a word association. You don't have to define it, but what comes to mind when you hear the term sexual health? Virility, okay. Healthy behaviors. And finally, number three, sex positivity. So how, again, word association, you don't have to necessarily define it, but what comes to mind when you're asked or you think about or see the term sex positivity? Well-being, intimacy. Being comfortable with sexual health. Okay. The attitude towards sex in general, which tends to be, yes, very, very negative. So as we're looking at these, and again, there is no right or wrong, but this is just, we're identifying our starting points, identifying gaps in knowledge. So when asked about sexuality, what came to mind? Did you equate it with intercourse? Did you think heterosexual, heteronormative? You think classic relationship structures, man, woman? Did you consider anyone who was not able-bodied? And with sexual health, did you only define that within the context of disease? So did you only think negative repercussions or condoms, like our meme? Heteronormative is going to be looking at things through the lens of heterosexuality. So not considering alternative sexual expressions. I don't want to say alternative, but other sexual expressions, not LGBTQIA inclusive. And that's lesbian, lesbian, gay, bisexual, transgender, questioning or queer, ally or asexual, intersex. And finally, sex positivity. So again, that may be a term that you're familiar with, which we will get to, and it may not be. So how do you, if I say I'm sex positive, what does that mean to you? Does that mean that a person must like sex, as a person without boundaries? Do you think about, hippies and free love, or whatever, you think about when you think sex positivity? So just take a moment. You need to jot down some notes or ask any questions. So finally, we will look at the actual definition. So of course, there's different versions of these, especially with sex positivity, but I chose these particular ones and I got them from World Health Organization and the American, excuse me guys, Psychological Association. And I have underlined and italicized words that are sexual wellness adjacent. So just take a moment to look at these. We'll just take them. I promise I won't be the person that reads to you, but looking at these, just each one starting at the top: sexuality influenced by economic, political, cultural, legal, all of these things combined. And sexual health. So we have emotional, mental, and social well-being. So not merely the absence of disease, dysfunction, or infirmity. And finally, sex positivity. And this just means, I'm going to put this in my own way, that you are open and you're accepting and you're open to learn about different ways of sexual expression. Yeah, I think that's a good definition, but please let me know if you have any questions about those. And as we are looking through these, are there any components of that were surprising to anyone, of the definitions? Any that you had not previously considered? And again, just jot those down if you're not comfortable answering. And I use those definitions before I begin addressing the circles of sexuality, but I use those definitions again to just begin to challenge what we think, how we think, and how we've been conditioned around sex. We will begin to draw parallels between sexual wellness and mental health. And you can see that we're already seeing lots of overlap, that these things are inextricably linked. So the circles of sexuality, I really like this version of it. I apologize for the small writing, but I mainly want for you to pay attention to the different categories. So in bold within the circles, this is a visual representation that I think does an excellent job illustrating the complexities of sexuality and how it is not just intercourse, right? So this is used by advocates for youth. There is a lesson planned, I believe, used by Unitarian Universalist Church in their OWL curriculum, which is Our Whole Lives, that uses the circles of sexuality. That's a K through 12, possibly beyond, comprehensive sexuality education. And so we're paying attention to those titles of the categories. And as we move on, excuse me guys, I have lots of information here. So as we look at the categories that were contained within the circles, all the things that come together to make up our sexuality, and we look at, I just have listed some topics here that could fall within those circles of sexuality categories that could possibly impact mental health. Some of these may fall into more than one category, but I have chosen just one or two from each category for us to consider. So intimacy is at the top. And with intimacy, for instance, if someone were going through a divorce, then that may lead to depression and anxiety. Moving on to sexual identity. So we're thinking about gender. So if a person is transgender or gender non-conforming, do they have an accepting support system? Do they have dating issues? How could that impact mental health? So again, looking at these components through the lens of how could that impact mental health. Under sexual health and reproduction, possible impacts on mental health if a person is going through infertility treatment. If they have an abortion, how could that impact mental health? And under sexualization, if a person has sexual trauma or any trauma in general, how could that impact their mental health? And finally, under sensuality, so sex and disability or sex and aging. How could that impact our mental health? Any questions so far? I know Susan had me define heteronormative. Sometimes I get in my sex educator mode and I forget that not everyone around me might not be familiar with the terms that I'm throwing around. Okay, so no questions. We will move to our next slide. So this one I know you guys are familiar with. This is our biopsychosocial model. I acknowledge that there are limitations to this model and that it is not liked and favorited by everyone, but for the purposes of this presentation, it's going to achieve what I want it to achieve. So we're considering these categories. We're almost looking, we're looking at the interconnection of factors that could play a role in mental health. So these could also impact sexuality and wellness. So as you see, we have our model here, we have mental health in the middle, but these could also be factors that could impact our sexual health. So we're beginning to see the intersections, we're beginning to see all of this overlap between sexual wellness, mental wellness. And again, I have just chosen a few of these that could impact not only our mental health, but our sexual wellness. So psychological, as we talked about, this was included in our circles of sexuality. Is there a trauma history? Moving to social and environmental. What is the impact of geography? And I will get to that more in just a moment. But does anybody want to take a stab at that? How could geography impact either mental health or sexual health? Weather, yeah, for sure. Weather and seasonal affective disorder. Absolutely. And biological access to resources. Yes, perfect. So our biological, and again, is the person able-bodied? Lack of sex ed in the state? Yes, I'm about to get to that. Thank you. What types of medications are they on? Yeah. Sexual orientation, the acceptance of sexual orientation, of gender. Again, so different perceptions, different receptions, I guess I should say, to different things that may not be, again, heteronormative, or may not be what a person is used to seeing. And before I delve into this slide, it may seem like I'm taking a hard left on you, but I really feel like in order to bring a multidimensional awareness to all of the ways in which sexuality could impact our mental health and our overall well-being, as clinicians and providers, you guys want to be, you want to ensure, excuse me, that you are addressing each piece that is part of the overall picture. So it's part, yeah, living isolated. These are all, you're answering exactly how I want you to. So I'm like, yeah, good. So I'm reading these. But if we really want to make a change in the lives of our clients, then or you guys in the lives of your clients, then you consider, in your approaches, you'll consider their wounds, their, I hate saying this, but emotional baggage, cultural history. And that's going to be heavily impacted by their sexuality. How do they learn about sexuality? And that's why I included this. So our sex education in schools. And as you can see at the top paragraph, this is just reiterating everything that I've already said. So sex education in schools is looked at through a framework of unintended pregnancy through the lens of disease. It overlooks critical topics such as the information and skills needed to form healthy relationships and content related to sexual pleasure. So this can be very problematic. This is going to inform people's knowledge of sex. And I bring this up for a multitude of reasons, but I think that it should be considered in your approaches. So as you are interacting with a person, and you may want to consider when we discuss geography, so that's going to be, is a person living in a rural area? Do they have barriers to resources? Do they have, what kind of education do they receive in schools or lack thereof? So this is why we're considering this. And this next things that I chose are from the Guttmacher Institute. And there are a plethora of them that are very shocking, but I chose these three because I think that they really stand out. 24 states and DC require information on asserting personal boundaries and refusing unwanted sexual advances. Only 9 states require the importance of consent to sexual activity to be covered. And 17 states require program content to be medically accurate. And as of the time that I submitted these slides, South Carolina is not one of those states. Are there any questions about that? So before I get into these quotes, I think that we all know and we can agree that sex education in schools, ideally it should reinforce what is being taught at home. But again, if you consider all of your contributing factors to and overlapping factors of sexual wellness and mental health, our family of origin, where we live, what types of schools we're going to, our income levels, things like that, that is going to impact the type of sex education that we receive or we don't receive. And I do just want to stress that each state determines the content of sexuality education, and there is no standard curriculum. And I do have a quick quote that I think really drives home this information, and I did not include it in these slides because I just happened upon it the other day, and I think that it's kind of funny, but it is it's a really good quote. It is from Eric Sprankle, and that is not my accent. That is how he spells his name. It's with an A. And he has a lot of social media content that advocates for honesty in sex education. He's a human sexuality professor out of Minnesota, but he said, a sex ed class that focuses only on STIs is like a wood shop class that only focuses on table saw injuries. Please say more about 9 states are not requiring consent. Let me look at someone had a question. Hang on just one second. So according to the Guttmacher Institute, there was a question asked about the second bullet on slide 13. It says 9 states require the importance of consent to sexual activity to be covered. So what that means, a little bit of clarification on that, is only 9 states out of our 50 states and DC require for any kind of information, training, any kind of education on asserting personal boundaries, bodily autonomy. So those are all things that are going to be or should be covered within education surrounding consent. Did I answer that question for my asker? I hope I did. When you look up the Guttmacher Institute, what it looks like is it's a grid, and it has things at the top that, does the state cover this? Does it cover this? And then the states are listed on the bottom, and it's X, it doesn't cover this, X, it doesn't cover this. What is definition of rape? That's another presentation. That's a really, really loaded question. A definition of rape is going to be any sexual activity without a person's consent. And again, I could really go on to that, because then it's like who gets to consent, what is the age, what is the this, what is the. I will say this about consent. If you need to remember how you define consent, you think about fries, like French fries, F-R-I-E-S, and it's freely given, informed, reversible, enthusiastic, and I can't remember the last one, but it's fries. That's an acronym for how people remember it. Talking about 9 states. Deborah, I'm so sorry. I'm going to get back to that question at the end because I'm not really sure. I will get to your question, but we're going to go ahead and advance to this, or to the next one. I'm sorry. So next we're looking at some quotes, and of course we will get more into these, but these are from an article I found on goodtherapy.org called The Importance of Addressing Sexual Issues in General Therapy. And I chose these because I think that they speak volumes as to how uncomfortable people are when it comes to the topic of sexuality. So Maggie's quote, which I will address in just one moment, but she says, "These things sound like they would be better left to the family doctors and not the therapists." And Genevieve says, that just grosses me out. Work those things out in private between the two of you and don't bring someone else into the bedroom. So again, we'll get to Maggie's quote in just one moment, but focusing on Genevieve's quote here, considering all of the topics, now that we've expanded broadened our scope, expanded our definition of how we consider sexuality and all the things that inform it, I think that Genevieve here, this is an assumption, but I think that she's equating this with, she would be a person that may equate sexuality with intercourse. So she's not considering all of the complexities and the nuances that come together to form our sexuality. So when she says, don't bring another person into the bedroom, there's a ton of things that come to my mind. So what if there is mismatched desire? So perhaps one person is on an SSRI and they have low desire, and the other person has higher desire than that person. So mismatch, that certainly would need to be addressed. And an SSRI, of course, you guys know what that is. But if a person were on that, then that is something that a therapist or a psychiatrist or whoever is managing that medication should address. What if there's a trauma history? So again, we need to consider all of these things. We're not just thinking about intercourse when we're talking about sexuality. And I think that there are many implications here on these, for these two quotes. And I think that they are indicative of how this topic is steeped in shame, and it's very, very misunderstood. And we think about, again, things that were contained within the biopsychosocial model and the circles of sexuality that may have informed this kind of messaging for people to think like this. So we do live in a very sex negative culture. So now we look at sexuality education receives, so outside, we're beyond the schools, right? So beyond K through 12 or throughout college. And I chose these, or I included these because I feel like they are very indicative of perpetuating an aversion to sexuality information in our sex negative culture. So I said I would get back to Maggie's quote in a moment. So medical school curricula, only 3 to 10 excuse me, hours during 4 years of study were dedicated to sexual health, and the coverage of sexual health topics was often arbitrary and inconsistent across the United States. And as we look at the next bullet, comprehensive sexuality education should begin in early childhood and continue throughout a person's lifespan. So another reason for me including this is when I think that when people think about sex education, they only think about sex education in schools. So we're thinking within, we're boxing it into that K through 12. But consider, again, all of these components of it. Consider sexuality and disability, sexuality maybe after a cancer diagnosis, sexuality and divorce or aging or anything like that. So as we change, which we do throughout our lives, we're going to have different goals and different ways that we want to live our lives, and we're going to encounter different issues, and it's going to just necessitate a different approach to all types of education of how we live our lives. So our life is about, learning. It's a learning experience. So our sexuality education, I just want to encourage you to consider it beyond, so not taking an ableist or an ageist approach. So we're thinking about sexuality across the lifespan. That was a lot of, yes, Toya, thank you. Freely given, reversible, informed, enthusiastic, and specific. And I think that specific in some lesson plans, it also can mean sober, because you cannot give consent if you're under the influence of drugs or alcohol. Thank you for looking that up. So this is a lot of information, and I know that in this new reality that we're in, you may be experiencing a little bit of Zoom fatigue. This may be just, droning on, but if you take nothing else away from this today, I do want for you to, I did just do some takeaways for you. So when we think about sexuality, if we just think about it as multidimensional, consider the overlaps and the intersections with mental health. With sexual health, so much like mental health, it is not just about the absence of disease. So it's about healthy relationships. It's about making sure if we're on medications, making sure that they're not having any adverse side effects. It's just about all of these things, making sure we're in a right mental space, that we're getting exercise and things like that. And finally, sex positivity. And again, there are so many versions of this definition, but just so the way that I like to define it is it means you are accepting, and again, this is just wrapped up in a neat little box. That would be a whole other presentation in and of itself, but you're accepting of different ways of sexual expression as long as they are consensual and risk aware. And I just encourage you, as you are interacting with clients or patients or whatever term language is applicable to your role, that you're always a student, that you're always open and you're always learning about that. So that is just how you would be sex positive. So I need your assistance. I am very encouraged by the progress that has been made in mental health conversations and bringing them to the forefront, in normalizing them and discussing them. And I would like for everyone to consider taking that same approach to sexual wellness. Normalize, legitimize, destigmatize. So by normalizing conversations, so we're encouraging, we're promoting these conversations around sex and sexuality, and that will increase people's comfort to discuss. So applying a sex positive approach, being open. So therefore the topic is normalized. legitimized. So by acknowledging the significant role that sexuality plays as part of our overall well-being, we encourage people's perception of it as a worthy and acceptable topic to discuss. So we're not sweeping it under the rug, we're not shaming anyone. The topic is legitimized. And destigmatized. When sexuality is deemed as a normal and valid topic, and we're comfortable to discuss, this will reduce shame and embarrassment and contribute to the topic's acceptance, and therefore the topic is destigmatized. And again, this is all of my encouragement that's gained from my mental health people, reducing that stigma. I know that's ongoing. I know these conversations have to continue, but I encourage you to also, again, take this approach when we are discussing sexuality and when we are thinking about these interacting, again, with our clients, etc. And I will get to some questions in a moment if anyone has them. But I want to thank Susan for inviting me today, and I want to thank Mental Health America. I'm just always grateful for a platform to promote these conversations and really changing the narrative and how people think about sex. And again, I think I am in good company with mental health professionals, because I think that you guys are very, very familiar with the ways that people have historically viewed mental health. And that is another overlap. That's a way that people view sexual health, and they may be averse to talk about it. And looking at, I believe his name was Roger that went before me, his presentation, and you may be, as Susan said, you see all of these letters after everyone's name. So my presentation today, as people continue, as you are viewing everyone else's presentation, thinking about mine today, you'll notice there's not peer reviews, there's not medical journals, there's not a lot of, it's not statistics heavy. What I'm encouraging you to do is just change the way you think. I'm shifting your perspective. So that was, that's the basis. That's what I do. So if you have any questions, I'm happy to answer them now, or I will try my best. If you have any questions that or anything that's outside of this presentation that you need to contact me, if it's Piedmont Care related, so if that's you need information about free HIV testing, free condoms, you want to be a condom distribution partner, you don't know what that means and you want to know what that means, you can email me at lori@piedmontcare.org. And if it is something ASEX related, or if it is something sexuality education related, or, hey, I don't really, I think I need to refer out to a sex therapist or something of that nature, then you can contact me at my personal email. And did anyone have any questions for me? I know there was one that I did not get to.
So we'll give a few minutes for folks to put questions in the chat. And in the meantime, Lori, as you know, I'm always full of questions.
You have great questions. I love your questions.
ASEX certification. So I only know a handful of people who are ASEX certified in this area. Can you just give some insight into what that process was to get that certification?
Sure. So the program that I went through at the University of Michigan, it required a bachelor's degree, which I do have, but I've worked in public health for since 2013. And specifically with Piedmont Care for almost 5 years. So it did require for you to have a certain amount of experience in a sexuality education related field. Now in my cohort, there were therapists, there were OBGYNs, there were doctors, there were all kinds of people that came together to complete that program. So for that program, you complete core knowledge areas, you get anatomy, reproduction, basically all of the things that are within the circles of sexuality. You go through hardcore training. When upon completion of that program, you don't have to pursue ASEX certification, but that was my ultimate goal. So what that process looks like is I had to, it's almost similar to my understanding of how a therapist's kind of training works. And again, I'm not a mental health professional, so I may not be using the correct language, but I had to undergo group supervision and also individual supervision. So I had, it was actually, I consider her my mentor. Her name is Sally Foley. I was in her last last supervisory group. She is retired now. But she, I think there were 4 or 5 other people in our group. So that went on for, you think I would know this because it's so recent, for about a year. I did group supervision with her for about a year, happened over Zoom. So people just came together. We talked about projects that we were working on. Two therapists in the group would say, I have a client that, is presenting with this, and how do I handle this? And she would coach us and mentor us through these issues. Individual supervision, Sally worked with me about, I'm nervous about this, or how do I approach this? She had to, I couldn't set it up in a way, I'm a little technologically challenged, but I couldn't set it up in a way where she could view it, but she did listen to some of my presentations, offered feedback. We had to practice with her. So things like that. So after you do those things, of course, that does not guarantee ASEC supervision. Then you have to compile a very, very complicated application. And my application, just to give you an example, was about, I think it was about 115 pages. So you have to document everything you discussed in supervision. You have to document all of your knowledge, your required hours of education that I received at University of Michigan. I'm trying to think of, and there were things that some trainings that I had done through Piedmont Care that applied to certain education hours. So I've been through tons of HIV, AIDS, STIs, things like that, those types of trainings, providing those certificates and the content that was covered. So that's a little bit, I know that I'm droning on, but that's what certification looks like.
So it sounds very specific, and like certain other programs, it's a process. It's not
exactly.
It's not a send in a check kind of thing.
Exactly.
Okay.
Yeah.
One other question that I had, I know that you use some terminology that that has not quite yet necessarily become commonplace. So sex positivity is one, heteronormative. Is there a source for culturally sensitive and aware terminology so people can get more educated on sexual health and wellness?
Yes, so there are several that come to mind. The resource that I mentioned when I was talking about the Circles of Sexuality, Advocates for Youth, that website, it is very, very informative. I think that they have some like a glossary. I know Scarletine, it's just like Scarlet, like the name Scarlet Teen with that at the end. That's a good one. And also, if it's something that you want to know more about, you want to know more about sexuality studies, all of these things, I would like to recommend the book Come As You Are by Emily Nagoski. She is a sexuality educator also, and I believe she has a couple of TED Talks. She's just a really engaging speaker, and she takes a really unique approach to her education. So I think that would be for anyone who was interested in furthering their sexuality education. And again, it's not about being an expert. It's not about being an expert in all of these fields, because it is so, there's so many topics, as you see. I mean, there are just a ton of topics that fall beneath the umbrella of sexuality studies, but it is about just being open and being accepting to learn. So I think that those are some good resources to start.
Okay. Thank you. And
Thank you.
You also mentioned shame. So can you talk a little bit about the connections between shame and sex and sexual actions and behaviors, and how that impacts people and their health and their relationships?
Absolutely. And I think there's different perspectives that could be applied to that. And again, I think that I mentioned so many other things that could be their own separate presentation throughout this. But specifically, like if a person is homosexual or bisexual, or if they are transgender, so you think about what type of support system does that person have? When did that person begin to notice that, you know, some things that, you know, I am not attracted to this, but I am attracted to this? And how is that reinforced, or how is that encouraged, or how is that kind of tamped down? So that's going to be contingent upon family of origin. And again, if the geography, the place where they live, is it you know, a more liberal environment, a conservative environment? Is it rural? So specifically for Piedmont Care, that's one of our big things. We do serve Cherokee and Union counties as well. So those are rural areas, as we know. So I absolutely am thrilled when people invite me out there to do education, because some folks may have barriers to transportation and they can't have access to those. So all of that to say that if you have not a heteronormative sexuality, if you have a different gender expression, if you have different sexual orientation, all of these things are going to contribute or inform how comfortable you are expressing that, or how comfortable you are just basically living your life and being who you are. Did that answer your question?
Mm-hmm. Yeah,
Okay.
I know from my perspective and my experience, it gets to be pretty complicated. There's a lot of contributing factors, but what I've observed is that if there is shame connected to that and it becomes deep rooted, then that definitely creates a mental health issue. And even in therapy, people aren't always comfortable talking about some of those very, very deeply rooted issues. So.
Right. And I think that was, that's why I chose the two comments, the comments from the Good Therapy article, because I think that they did, like I said, a really great job of illustrating how, you know, those seemed like very steeped in shame comments, and very, you know, misunderstood about any of, you know, the things that make up sexuality, misunderstood messaging or negative messaging or lack of messaging about just the whole issue. So, and they were just very, very negative. They seemed very negative and very uncomfortable with that topic.
Okay. Well, thank you so much, Lori. I don't see any other questions in the chat, but you've shared your contact information, and I know Toya put it out there also earlier. So I encourage folks, if they have questions or comments or need connections to resources that didn't come through today, reach out to Lori. Lori, thank you so much for sharing your expertise and your knowledge with us. We are going to take a short break. Let's see. We are going to take a short break, and again, sitting is the new smoking, so take this opportunity to stand up, stretch. You know, I know I'm going to let the dog out, that kind of thing, and we will rejoin at 11:20 for child and adolescent social isolation with Courtney Bergen. See you shortly. Hello, hello, and welcome back for our third speaker and presentation of the day. My name is Susan Lee. I'm with the Advisory Board for Mental Health America Spartanburg. Our next topic is child and adolescent social isolation. Our speaker is Courtney Bergen. Courtney is a licensed master social worker and current doctoral student with a focus on adolescent mental health in her dissertation. She is originally from New York and received her master's degree from Adelphi University in 2017, shortly after she moved to South Carolina. She is currently employed as a clinical counselor / eating disorder body image counselor with Spartanburg District 6 schools. Before being employed by District 6, she had the opportunity to work at Spartanburg Area Mental Health Clinic as a school-based clinical supervisor and eventually promoted to school-based mental health coordinator. She has several years of experience working with the Department of Juvenile Justice, the foster care system, and children and adults with special needs. Throughout her social work career, she has been given the opportunity to develop a passion for working with adolescents and children that continues to show through the work that she does. So I would like to welcome Courtney to the Mental Health America Symposium. Hi, Courtney.
Hi, thank you for having me.
Absolutely. I'm gonna, if you'll bear with me just a moment, if you wanna share anything with anybody while I pull up your presentation.
Sure. So not only will we focus on just social isolation, we're going to focus on also how social isolation during COVID has definitely significantly impact our children and adolescents and what we can expect in the future. So hopefully you guys will get some useful information out of it.
And remember, folks, put your questions for Courtney in the chat. Toya and I are keeping an eye on that chat. Sorry, I'm almost to your presentation, Courtney.
You're fine.
It would help if I didn't have 47 tabs open at one time. But here we go. I just need to. Uh-oh. One more. The one thing COVID is teaching me is reminder of extending grace. So there we are. Okay, here we go. We're good now. Thank you, Courtney.
No problem. Okay, so today, again, we're going to focus on social isolation, children, adolescents, and COVID-19. I'm sure that we can all agree that there has been significant impacts from COVID-19, not only on just mental health, but, you know, our economy, our unemployment rate, and all of this has to do with the outcomes we're going to talk about today. So some of the learning outcomes is to discuss the impact of social isolation on children and adolescent mental health. All right. So when we talk about social isolation, social isolation can be associated with quarantine, and it has the ability to be a catalyst for mental health diagnoses, even in those who are deemed previously mental health well. The changes in usual life, as we all know, can make people, you know, feel anxious and unsafe. It's the fear of the unknown, I like to call it. It can lead to diagnoses such as acute stress disorders, emotional mood disorders, which include depressive symptoms. Some of the effects that are associated with social isolation are hypervigilance, inability to focus, sleep disturbances, irritable mood, and outbursts. Some of the emotional disorders we have are major depressive disorder, bipolar disorder, and dysthymia. So getting down to the specifics of social isolation in children and adolescents. When we talk about children and social behavior and interaction is vital during childhood development. There are 5 critical domains to childhood development. They are social, emotional, physical, cognitive, and language development. So peer relationships during school is especially important to childhood development. Adolescents and children are already considered high risk. And when we talk about high risk, we mean they're more vulnerable to mental health diagnoses. And that's because of the social pressures and biological changes that they experience during these times. When we talk about children, and in preschool, we talk about the social development for them is being able to interact with younger kids builds that foundation on learning how to interact with those peers. So why that important is because, sorry, I'm super nervous, so if I'm talking really fast, just bear with me. So preschool builds that foundation. It's just learning how to interact with peers. It's learning how to make friends, how to interact with people outside of your family. When we talk about grade school, it's beginning to understand the relationships between action and consequences. We're refining those social skills. We're learning how to develop more mature relationships with peers, and learning that when we have actions, they also have consequences, and that's super important in school. Adolescents need socialization to mature. Their brain is still developing. So when we have canceled activities such as prom, graduations, and sports, it leads to no external motivation for them, which can also lead to depressive and anxiety symptoms. So back in June, when things were starting to get canceled, you know, kids were very disappointed that everybody looks forward to prom, everybody looks forward to sporting events, graduations. So those are landmarks, and I guess adolescents look at it as a sense of purpose for themselves. It's okay, we've reached this milestone, now it's on to the next. And without that, they're kind of left with those feelings of uncertainty, we can say. So when we talk about that, social distancing and school closures directly increase a child or adolescent's feelings of loneliness. And those feelings of loneliness can lead to behavioral issues, social withdrawal, and an increased risk of substance abuse. And when we talk about emotional disorders in children, we're talking about the inability to maintain interpersonal relationships with peers. Now, those, again, are significantly important to functioning and can lead to poorer outcomes in adulthood. I can't get into the chat box. Oh, here we go. All right. So again, when I said that these can lead to, you know, extenuating circumstances in the future, existing research demonstrates that social isolation during childhood has long-term negative health effects. So when we talk about those mental health effects, we're talking about depression, increased anxiety, lower self-esteem, sleep disturbances, increased suicidal attempt and ideation, and increased risk of substance abuse. The physical effects of those are just worse physical health overall. We have a higher cholesterol, higher blood pressure, increased risk of obesity, and poorer cardiovascular issues as well. And this is just not having anything to do with COVID. This is just with social isolation in general. When we add the effects of quarantine to this, like I said before, it becomes a catalyst for mental health issues. Okay, so COVID, now we're going to get into COVID. So this was especially interesting to research for me because there is not a lot of information on it because, as we know, COVID literally just became a thing in March. I was working in the schools when they abruptly, you know, closed, and everybody was kind of left wondering, like, what the heck is going on? It changed the lives of millions of people, not only here in the United States, but worldwide. We saw complete countries going under lockdown for extremely long periods of time. The death toll has significantly risen. I don't think people imagined it to be this high. So when schools shut down, you know, it drastically altered the lives of the families, and nobody knew the impact that it would have. Nobody knew how long this lockdown was going to be. Nobody knew how long, kids were going to be out of school. What is virtual school? Nobody really knew what that was going to look like either. Planned social activities and the ability to see extended family members were now completely indefinitely suspended. You were only allowed to stay with your family. So this was, a trying time for not only children, but for families as well, especially those who depend on childcare to go to work. I know that some jobs, people are essential workers, they still need to go to work. So these are all kind of effects of COVID. Many parents had to leave their jobs. So they left a stable job because now they have to care for their kids. So, that also has a significant impact on, not only children's mental health, but a parent's mental health. Those who had the ability to work from home, well, guess what? They were becoming full-time teachers and full-time parents and full-time employees all at once. Nobody knows how to navigate that lifestyle. And there's an adjustment period, and I don't think people were given that period to adjust. It was just being thrown in and saying, all right, let's see what you can do. And today, currently, we're seeing, not only, people losing their jobs, but, mothers are significantly leaving the workforce in order to stay home with their children during this time. So, we're seeing a significant impact on women as well, who are now becoming full-time, teachers and homeschool moms, pretty much. Okay, so what defines a quarantine? So Webster Dictionary defines quarantine as a state of enforced isolation. I highlighted and bolded enforced because this is a forced isolation. This is not something that is of free will. People told us to stay home. We needed to stay home. We weren't allowed to go out. We had no choices pretty much in this. And then it's to isolate from normal relations. Obviously, there was no more normal anymore. Normal was, taken off the table. We had to adapt to the changes. Another effect of the quarantine was that parents and community members have been the recipients of many mixed messages. Everybody has their own opinion about the COVID-19 pandemic, whether some believe it to be as serious as it is or not as serious as it is. The truth is everybody's getting mixed messages. One day it's you can go outside and be fine. The next day it's like, oh no, you need to quarantine for 14 days. The CDC changes their guidelines, on a daily basis. Who can go to work? Who can't go to work? Who can go to school? Who can't go to school? How long do you need to quarantine for? It's very confusing, and it gives us this feeling, this uneasy feeling and unknowing. Continuously changing safety procedures again and protocols. Each state has their own procedures and protocols. No one state is the same when it comes to mask mandates, where you can travel to, where you can eat outside in a restaurant, if you can even go inside in a restaurant. It's all very confusing. Again, it's not a uniform thing. So everybody's life is different. So there's not even that opportunity to connect with others in the community again because of all of these mixed messages. And again, we've been under this quarantine since March of 2020 with, reports now saying it's only going to get worse as flu season comes about, or it could be steady. Who knows? I mean, it's those feelings and unknowingness. Okay. So there was a recent study done in Time magazine. It was done in China. Time magazine actually published it, but it was from JAMA Pediatrics. So a sample group of 2,330 students were examined for signs of emotional distress. I want you to keep in mind that these were school-age children that had only been in lockdown for 33.7 days. That was it. So it was only like a month compared to kids being out of school since March, correct? And in that short period of time, 22.6 of those school-age children reported depressive symptoms. So that is I know it's not like 50%, 70, but we're talking about 22% of those kids only being locked down for 30 days, which to me is pretty significant. And then 19 reported feeling anxiety symptoms. So again, very short term, and they were already feeling those symptoms. Okay, so here's another study that I thought was also interesting too. This was a national survey done here in the United States, and it was given to parents with children aged less than 18 years old. So out of this survey, 14% reported worsening behavioral health in their children. And the article goes on to state that these behavioral changes were acting out, a change in attitude, the limited self-care, and their ability to interact with others, and their growing reliance on technological devices. I mean, my dissertation is also on adolescence and smartphone use. So I was really focused in on, how technology is going to significantly impact mental health, but it's also something I'm going to touch on after this. Another outcome was limited access to school-based mental health services and office mental health services. So not only are these kids being isolated, they're being isolated from the services that were being provided to them. I know Roger talked a little bit about we were providing telehealth, and telehealth was great, but we have to think about the different circumstances for kids receiving telehealth, who our audience is for telehealth. And like Roger said, there's always that confidentiality issue of who's in that room with those kids when we're providing these services to them, and what are they able to tell us in confidence. It's a huge difference going from in-person services when you're sitting face-to-face with that person and you can talk to them and it's just you two in the room, to now being at home and your privacy is pretty much gone. Again, limited abilities to interact with others and difficulty navigating the new normal. A lot of kids, unfortunately don't have access to internet. I know that was a big problem when school started and South Carolina was trying to roll out a plan to get hotspots put in places. Buses were going out to communities that didn't have Wi-Fi and giving them the ability to connect so they can connect to school. There's no access to technology. A lot of kids don't have, Chromebooks, iPads. There's just not the ability of parents to be able to, get them those supplies. And when they were in school, they didn't necessarily need those supplies either. Another issue is that children with ADHD diagnosis have a harder time concentrating using a virtual platform. I'm an adult and I have difficulty using a virtual platform. And it's very distracting when you have a million things in front of you and you just want to go on and play this. And kids with a computer in front of them, they don't exactly want to listen to you. They want to go search Google and see what they can find, go on YouTube. So again, these are just some of the issues that came out in the survey. And another thing to note was that not only are the kids feeling this, it's the parents are feeling this too. So it's also something to keep in mind as well. So why this is especially affecting children and adolescents. I've bolded some things in here because I think it's super important to remember these. It's the inability to comprehend the pandemic, the unknowingness, like I said a couple of times, and the confusion. It's, young age students are unable to comprehend what COVID-19 is. A lot of them just think, oh, I can't go outside because I don't want to get a family member sick. Okay, well, that leads to the fear of getting family members sick. So now you're instilling fear because of this pandemic when they don't really actually comprehend what the pandemic is. Separation from important family members. I know a lot of you who have Facebook, I'm sure you've seen the stories where nurses and doctors were not being around their kids because they were working in the hospitals and they had the fear of bringing that home. So now these kids are being separated from their parents during an important trying time for them. And that's going to lead, that could be very traumatic to them. It's attachment. They need their parents, especially during, periods of fear and confusion. You have death of family members. A lot of people, again, are losing family members to COVID-19. So you have kids dealing with grief who don't have people to talk to, who don't know how to correctly express that grief, who don't have access to, therapists, who don't have access to healthcare at this time. they're unable to develop those social behaviors and engagement, which is important to development. If we went back to, the first couple of slides, social isolation, plays an important role in how a child will develop. If a child's not interacting with peers, they're not learning those, social and emotional pieces that they need in order to develop more functionally. Another piece is that the children have become more reliant on technology. And that's just to help them combat their loneliness. It's the only way they know how to interact with people when they're not allowed to go outside and interact with people. They're using technology for not only educational purposes, but to connect with peers. But, that leads us into, who are they actually talking to on those computers? Are they being monitored? A lot of people, are off doing their Snapchat things, and, they're getting involved with people that they don't know. But this is also creating an increase of possible addiction to devices. In my studies for my dissertation, a lot of, school-age kids right now are becoming more dependent on, social media devices, that it's actually, having a negative impact on their psychological well-being. So that was before the pandemic. Now we have to worry about, okay, so now we're becoming more reliant on these devices because of the pandemic. What kind of outcome is that going to have on our children who already were at an increased risk for addiction to technology? Okay, so other risk factors for mental health outcomes in kids right now, I think is especially important to talk about, especially that has to do with social isolation, is the faltering economy and the unemployment rate. So the economy, it was not doing well. The unemployment rate continues to go up, right? There's an increased amount of stress, and that stress trickles down to the children in the household. Parents are losing their jobs. Parents are losing, their access to healthcare because they don't have that insurance anymore. It disrupts the way a family can function and seriously impacts those family dynamics. And that can lead to a lot of adjustment issues too in the future. The families face difficulties like sustaining any type of basic needs, such as food security and childcare. A lot of people depended on childcare in order to be able to go to work every day. Well, with daycare centers closed, or them losing their job and they can't afford daycare anymore, this is it's a circle effect. These risk factors can alter the way a child views the world. It's so much negative going on around them that they don't know how to correctly process that negativeness. So they are just looking at everything as, wow, this is just awful. Parents are also facing their own mental health issues. Roger had a perfect slide before where it shows that people who should be deemed healthy are now reporting depressive symptoms on a daily basis. That is going to affect the children in the household, especially if these parents are not receiving help for their mental health issues. We're going to see, secondary things trickle down. A big one is now an inability to report abuse and neglect. Reports of child abuse are down nearly 40% in South Carolina. And I don't believe it's because abuse just abruptly stopped. I don't think everybody is getting along now. I just think that kids are unable to report that abuse. So not only are they unable to report it, is they're living in homes where they could be being neglected, where they could be being abused, and it's not a good situation for them. And it's going to cause serious outcomes after that. And then the abuse may be becoming more prevalent. Students who may have never been abused before in the past, now we're adding more parental stressors onto that, making them at increased risk for abuse because of those stressors. And again, the reliance on technology. I like to talk about technology because of how important it's become to our world. It's been a growing concern. It's always going to be a growing concern. It's got its positives, it's got its negatives. The positives right now is that it's allowing our kids to connect with other kids. It's allowing them to have those social interactions when they might not be able to, go back to Big Air or go to the mall in a safe fashion. Parents are, not wanting to let their kids out still. People just don't feel comfortable. However, the boredom is creating this reliance on entertainment and interactions to where they're at an increased risk for not being safe on the internet. And parents are being asked to do, a million things. They're being asked to monitor their internet use, make sure you're creating a good social environment for them. Make sure they're doing their homework all the time, make sure they're logging into the computer. And parents are, there's only so much a person can do, I feel. So it's becoming extremely difficult to navigate everything that is going on. So like I said, the importance of school is while children were in school, they were interacting with peers and teachers. This helps with social development. Social development is extremely important. Without social development, we have an increased risk to not be able to function as adults in the future. We are at increased risk for physical issues, for mental health issues. We are just very highly at risk without correct social functioning, and school provides us that environment. We're able to, see kids, we're able to see our peers, we're able to interact with people that are just not our family. We get to make relationships with teachers, we get to form relationships with principals. SRO officers are extremely important. Bus drivers are important too. And like I said, these are all the people that spend a lot of time with these kids who can report when things are going awry, when we think people are being abused, when we think that children are being neglected. So this is an important, place for kids to be, especially with seeing a nurse as well, because you're helping these kids make sure that they're getting taken care of. So again, while children were in school, many were receiving food and free and consistent meals. Food security is a big thing. With COVID-19, we saw a lot of shutdowns of things, and that includes, churches and soup kitchens and, things that people relied on. There was a backlog in who can receive food benefits. People lost their job, and it took a while for unemployment benefits to kick in. When these are going on, school was actually the place where they could still get those free and consistent meals. A lot of the schools, though, were really good during the pandemic with being able to still deliver those meals. However, that can only go so far. We're talking about weekends and things like that. There's times when, kids need to be around people that can ensure that they do have food security. When children were in school, again, many were reporting violence in the home. So again, we have safety. And while children were in school, they were able to disconnect from that technology. We have development. So we have development, food security, and safety, and these are all important factors in a child's development and making sure that they are functioning the way that they should be functioning. So I guess one of the big takeaways is that, children are extremely resilient. We know that. Children are resilient. Studies have shown that, lockdowns and quarantines are, poised to have minimal risk on kids. However, when we include a forced social isolation, kids are used to being punished for things. However, grounded from technology, things like that. But when it is forced on them and there's that fear of the unknown, and we throw in all of these other things, COVID, the fear of getting a parent sick or a grandparent sick, not being able to see your grandparents, not being able to see your parents at times. There's other risk factors that go into that isolation to where children can still feel extremely lonely and vulnerable during this time. And without the proper help, it could definitely lead to a lot of negative outcomes in the future. So this is how we can help. And I downloaded this from the World Health Organization. When we read it, it says children may respond to stress in different ways, as to being more clingy, anxious, withdrawing, angry, agitated, or we can see an increase in bedwetting. So it tells us how parents should be reacting. Respond to your child's reactions in a supportive way. Listen to their concerns. Give them extra love and attention. Yes, that all sounds very good. but I think we're taking away from the fact that everybody is feeling some type of stress right now from everything that's going on. So as providers, it's important that, you know, when we see kids, whether we work in a school, whether we work in a facility or community mental health agency, you know, that we're addressing those, you know, clingy, anxious, withdrawing, angry, or agitated symptoms, you know, and that we're helping to give that attention that's needed. Children need adults' love and attention during difficult times. Again, that could be very difficult during this time. Parents have to go to work. Caregivers, you know, such as grandparents and stuff, they can't see them anymore. So it's that period that we need to talk about, that they need that reassurance. So teachers, especially important to a student to reach out to them and give them that attention. Parents, try and give as much attention as you can. I know it's difficult, however, but kids need that reassurance. Kids need that love, especially during this time when they're confused and they don't know what's going on. Again, it's trying to keep children close to their parents, you know, and caregivers. That could become extremely difficult too, just because of everything that's going on. Keep regular routines and schedules. That is something that I promoted a lot when I was doing therapy with families, was keeping kids on a schedule. Wake them up at a regular time, make sure they get dressed, you know, shower regularly, still eat dinner at the same time. In the beginning, I will admit, a lot of the teenagers I worked with, they thought this was the best time ever for them. They never had to get dressed. They could do whatever they wanted. But then it started to really affect them. It got to be boring for them. And they were like, okay, I don't know what, you know, I'm doing. Kids and adolescents thrive on structure. As much as they hate it, they thrive in structured environments. And it really helps them develop that sense of responsibility. It's okay, I know I need to do this in order to do this. I have to accomplish this before I can do that. So it's extremely important to keep these kids on routines. You know, check their homework, make sure that they can still, I guess, attend any, you know, appointments as regularly scheduled. Another thing is trying to give them clear information. Like I said before, kids are super resilient. They might not understand what's going on, but explaining it to them to where they're comfortable enough to understand, where we can kind of diminish some of the fear, might be extremely helpful for them. The more information that you can give them in a loving, you know, non-scary way, the better it could be for them. So COVID-19 has definitely thrown us for a loop. It's, you know, promoted social isolation in a way to where we're going to see behavioral issues. We're going to see inattentive issues. We're going to see, you know, that ability to not be able to function in a social environment because of the isolation that they've incurred. So the best thing that we can do is try to promote as much interaction as we can. You know, get kids as involved as we can. Parents at home have a lot of responsibility to make sure that they can still, you know, interact on a daily basis with kids. Take them outside, you know, let them see their friends, you know, from a safe distance. There's a lot of the unknowingness, but there are some things that we can do to help prevent those issues from still occurring. And I believe the next slide will be my references.
Thank you, Courtney. If anybody has questions for Courtney, please put them in the chat. And as always, I know I have some questions.
Awesome.
So I know the topic was social isolation, but as you were talking, I picked up a couple themes. One being grief over milestones and landmarks. You know, we recognize this pandemic, but at the same time, you know, a high school senior or junior who doesn't get their prom or their graduation, they do grieve that. And when you combine that with the anxiety that's fostered by uncertainty and kind of the scariness of masks everywhere, it just seems like so many overlapping layers for kids to try and navigate through. So you mentioned family therapy, you mentioned support in schools. What are other things, other services we can connect families to help them meet these needs for their children?
I think a lot of the services include is just, each family is different. We need to assess each family as it is different. We don't know how this pandemic has impacted their lives. Do they need financial assistance? Do they need technology assistance? What can we do to make their lives a lot easier during this time? So individual, in an ideal world, we would still have our groups, right? But a lot right now, a lot of places are doing those virtual groups, even interacting with that, finding a sense of community in a way, having, meetings, with people in your community over Zoom.
Mm-hmm.
A lot of people were doing those Zoom happy hours.
Mm-hmm.
That was a way to connect. I know that right now, a lot more restrictions are lax, but I know that parents are still very much afraid, and people are still afraid because now everybody's talking about flu season and what's going to happen with flu season. So
Yeah.
the best thing we can do is try to, I hate to say it, normalize, how we have to see people. Make sure
Mm-hmm.
you're having, even if it's having daily phone calls with grandparents that you can't see.
Mm-hmm. Right. And I think the other thing coming up are the holidays. And normally people start getting really excited about that. Like right now, football games. Those are big for a lot of kids in our schools and even a lot of parents. And if I'm not mistaken, schools are being very considerate of protocol. And it's not like in the past when we would go on a Friday night to a really crowded football game. They're being careful with the number of tickets and that kind of thing. And schools, by the way, I don't know about all school districts, but District 6, the school district I live in, they have offered free lunch and breakfast to all the kids in the school district because they know that some are have the food insecure households.
And it's definitely amazing that they're able to do that. And, it definitely helps the parents who are struggling right now. But there are other, not just in the state of South Carolina, if we look at this as a nationwide thing, some schools are unable to provide that for them at this time. And that has a lot to do with funding and, what kind of assistance they're receiving during this time too.
Mm-hmm. And that's different for the schools to try and organize because the teachers are having to teach differently. There are those who are basically facilitators for virtual academy, still have to teach, and then they still have to be mindful of these, what can be updated COVID protocols. So the job of teaching has changed. The job of parenting has changed somewhat. And we've got a comment, excellent presentation, a difficult time for adults, a very troubling time for our children. Football games, plays, band, chorus, orchestra, a lot of loss of socialization opportunities in and outside of the classroom.
Yeah. At this time, it's an adjustment for everybody. It's what do we adjust to? Is this going to be the new normal? And, with mixed messages, it doesn't help us be able to adjust. It's always, we're in that period of, we don't know what's going to happen. And I love that, schools are coming back and schools are being extremely safe with the plexiglass and everything like that. But kids are having a difficult time adjusting to that as well. It's a whole new normal, and we have to treat it as, okay, everybody has this type of adjustment disorder right now. So how do we get them comfortable with what is going to be the new normal? But then how long do we know this is going to go on for?
Right.
We don't have any answers. We're in this, dark period of just unknown. So even as providers, we could do the best that we can, but people sometimes look to us as all right, what can we do about this? And sometimes we struggle with our own adjustment to everything that's going on. I know adjusting to doing telehealth was really different. That was an adjustment too. And you could see, like, in the beginning, it was great. But after a while, you miss that interaction you have with your patients. You miss that interaction you're able to have with those students. So it's an adjustment, not just for kids, parents, adults, for teachers, providers, for healthcare workers. Everybody is adjusting, and it's going to have a trickle down effect.
And I think that's the other thing about COVID. And again, I know that your talk focused on adolescents and children, but really COVID has affected in some way, shape, or form every sector of society. Because even if you're in an area where there aren't that many cases, even if you don't have children in schools, you're still dealing with, okay, now I go to the store, I forgot a mask, I have to go back home, or, oh, goodness, there for a while, who couldn't find toilet paper? So everybody has been affected to some extent. It's just so widespread.
Yeah, and you think of, people who have family members that live in different states. It's not like you can drive down the block to see a parent or something. If, say, I'm in South Carolina and I have a sister in New York, and I have not been able to see my sister in New York, and it's been difficult because it's family. I haven't been able to see my brother in Washington. So, and it's a big adjustment for my sister's kids too, because they are closed off from family members who don't live around them either. So they're 6 and 7, so they're missing, they're missing their aunts, they're missing their uncles. The way they interact with us now is over a Facebook portal, and it's not the same.
Right. It's definitely not the same. But one thing I have observed is that people are being more intentional with their connection with distant family. So even having dinner every Sunday, but virtually, like literally setting up the phone and talking to each other as they're preparing it, or, looking at virtual Thanksgiving. The point being that people are being more thoughtful, intentional about reaching out to others. So I think that may be a good thing that's coming from this.
It is. And I do think that, again, it's adjusting to the new normal. It's okay, so how can we make this as normal as possible despite the circumstances that we're going in? So the thing is with little kids, their attention spans are maybe
that big.
Maybe that big. So keeping their attention, being able to have those meaningful conversations with them are very limited. So whereas when you're with them, you could do things that help them interact. So it's finding ways to move around that. One thing I did is I would send them scavenger hunts in the mail.
Oh, I love that.
You write a letter to them with a scavenger hunt in it, and they have to do it. And then every week they would get a new clue.
Okay.
So it's teaching them what mail is because they don't, and getting them excited for when the mail comes. So again, it's about adjusting and finding different ways that you can work with those specific children and adolescents and still let them know that, hey, I'm thinking about you, even though I can't be there with you right now.
So being innovative and flexible too. Yeah. Well, thank you so much, Courtney. I don't see any other comments in the chat. I know that Toya Hancock with Spartanburg Regional Healthcare System posted your contact information a little bit ago in the chat, so folks can reach out to you if they have questions or want more information. I thank you so much for joining us and for your time sharing your expertise. At this time, we are going to break for what would normally have been a lunch of fellowship. And I know I missed that. I see some people that I know who are here today, some of my favorites I haven't seen in a while, and I see a lot of people I don't know. So I wish that we would be able to get to know each other. Unfortunately, I'll be having lunch in my kitchen, and hopefully you're having lunch something yummy where you are. We will reconvene at 1 o'clock for Dr. Shaquinta Richardson, who will be presenting on the topic on healing racial trauma, intergenerational perspectives for helping professionals. As as evident in the news, COVID isn't the only thing that's happened this year. Our society has faced a lot of civil unrest, and a lot of racial issues have brought to light. So Dr. Richardson will be sharing with us from her experience, her perspective, and her expertise. So if you do need to leave, you'll rejoin with the same link. And I look forward to seeing you all at 1 o'clock. Hello, hello. We've got about 2 minutes. We'll give folks those 2 minutes to kind of get situated. And while we are waiting, I will say for attending the 5th Annual Mental Health Symposium brought to you by Mental Health America of Spartanburg and Spartanburg Regional Healthcare System. After the last presentation, our advisory board chair will provide some closing comments, and she will also share the winners of a drawing that we're going to have for $25 towards next year's mental health symposium. So I hope you'll stick around for that. We will also send out through the chat instructions for CE. Those have been on slides in between speakers, but it's a lot to kind of read. So we want to make sure that you get that information. Mental Health America Advisory Board Chair is Mary Miles, and our members are Vanessa Thompson, Sally Owens, Peter Moore, Nelda Hope, David Cato, Kathy Emmerth, Kristen James, Jim Rentz, Mary Hope Rhodes, Casey Sims, and myself. So at this time, I am going to go ahead and introduce our next speaker. Her topic is on healing racial trauma, intergenerational perspectives for helping professionals. As mentioned before, COVID isn't the only thing that has affected a large sector of society in 2020, and it's definitely caused a lot of trauma and mental health issues. Joining us today is Dr. Shaquinta Richardson, PhD, LMFT, licensed marriage and family therapist, for those who aren't familiar with those letters. She is a clinician and researcher whose work centers the experiences of Black, queer, and disabled and non-traditional couples and relationships. She focuses on identity-related trauma, intergenerational trauma, communication, and resilience, and self-care as a form of resistance. She has worked in the nonprofit clinical sphere serving under-resourced individuals and is a former professor of marriage and family therapy. She is a native of Spartanburg who currently resides in Houston, Texas with her wife and 2 dogs. And at this time, I invite Dr. Shaquinta Richardson. And if you guys will bear with me a few moments while we get Shaquinta situated. Let's see. Shaquinta, where are you?
I'm here.
There you are. Did I get your bio? Did I read it all correctly?
You did everything that's there. I add that little last piece. I just got married recently also, and I'm going on honeymoon in 2 days. So I just wanted to throw that in there.
Oh my goodness.
Yes,
now, what I know is not in there is the name of your practice. It's Building Bridges. Is that right?
Yes, Building Bridges Family Therapy, and I practice solely virtually.
Okay, and you are licensed in this state, even though you're living in South Carolina. So if anybody who's here today knows a potential client or needs your consultation on your areas of expertise, they can certainly reach out to you.
Absolutely,
okay?
Absolutely.
Well, thank you for making time for us right before your honeymoon.
You're welcome.
Oh, absolutely. So let's see if I can get your presentation up and get started.
All right.
All right.
Okay, y'all. So she already gave all of the introductions and everything. So I'm a private practice clinician and former professor of marriage and family therapy. And I do work primarily with a lot of Black clients as well as Black and queer clients as well. So, and queer. So some intersections happening in the populations that I serve. But the kind of focus of my practice is working with people who have experienced or dealing with identity-related issues and trauma. So that is my focus. And I'm working from 2 screens right now, so please bear with me. All right, so I have my disclosure statement here, no conflicts of interest to note. So our objective today is going to be to provide some education and information around working with clients who have experienced racial trauma. And the kicker is that the majority of Black, Latinx, Indigenous, Asian, et cetera, clients have experienced this trauma on some level. So it's going to be a wide range of people. Now, to just kind of set the tone for what we're going to do today. So even since I have presented this information, or since I submitted my slides, we've already had two major racial events, as we'll call them, happen, since I did this. That was the verdict with Breonna Taylor case, as well as the murder of Jonathan Price. So I am going to try to stick to this PowerPoint as much as possible. That's not true. We may or may not stick to this PowerPoint, but I will make sure that we touch all of the points, we get through everything. I do feel, I believe that learning happens more through dialogue and understanding rather than just me going through the PowerPoint, but I will make sure that we get through all the information and the main points are conveyed, okay? So please feel free to ask me questions, ask for clarification as we go through, engage, all that good stuff, because as we all know now, doing presentations over Zoom is not the same. So I do encourage some, questions and dialogue as we go, and I'll, make sure we get to all of the good stuff. So in terms of setting the tone, you will hear some terms. You may hear some terms as I go through that you may or may not be familiar with. You may or may not agree with, but we're gonna call things things. We're gonna name them. I'm not gonna shy away from the terms. And so this is, just know what to expect as we go through. I ask that, everybody here comes into this with open hearts and minds. I know that things have been very, very tense in our country for a long time, but recently, even I want to say even more so, but it's just kind of been in our faces a lot more recently. And so I just ask that people, come into this conversation with open hearts, with open minds, fighting the urge to maybe defend or discredit what is going to be shared, and really kind of interrogate and come from a place of, exploration and understanding. Okay. So as to define anti-Blackness. And so anti-Blackness is a specific form of racism that is geared towards Black people of African descent, that paints, kind of puts Black people in the light of being violent, things that we do or say, or our culture is wrong, inferior, bad. And it is a pervasive, specific view that Black people are the lowest form of people in our world. So anti-Blackness specifically it's not specific to America, it's global. And so maybe we go to other countries, there's already this view that Black people are a certain way based on how we've been portrayed through the white lens in America. Any question there? All right. Excuse me. So I'm not necessarily defining all of those terms, but if there are any questions, because I'm sure people have heard them, but if there are any questions about any of those, please let me know. All right, so just to kind of set the tone, some of these things are, terms that we are familiar with, concepts that we're familiar with, but there are things that I want to kind of point out as I talk about them. So trauma, just as the APAs define it, emotional response to a stressful event, with some examples there. And then, how people respond after that. Unpredictable emotions, strained relationships, as well as physical symptoms, okay? Uh-oh.
Shaquinta, I apologize. I'm having a little difficulty with the chat box, so just bear
Okay.
with me.
Okay.
I think that let me get to the right slide. Okay. Is this it?
Yep, that's it. That's it.
Okay, great. Sorry.
Yep. No problem. No problem. Technology is fun. So I included the ICD-10 or ICD-10 first 3 criteria for PTSD as well, just to kind of get some language going around some other things that we're going to see as we talk about this presentation. And so with the first 3 criteria, a stressful event or situation, the part that I want to highlight here is the which is likely to cause pervasive distress in almost anyone. And so we think about death, we think about like fear of being discriminated against, fear of not being getting access to something. Like these are things that would provide or that would cause distress in anyone if they were to experience, but we'll get into something a little bit. Okay, the piece that I want to highlight in B is resembling, being exposed to circumstances resembling or associated with the stressor. Okay, so keeping that in mind as we go on, circumstances resembling or associated with the stressor. All right. Actual preferred avoidance of the circumstances resembling or associated with the stressor. Okay, so keep that picture going. Uh-oh. There we go. Okay, so specifically talking about racial trauma or race-based traumatic stress. Mental and emotional injury caused by encounters with racial bias, ethnic discrimination, racism, and hate crimes. Okay, so these can be as small as being followed in a store or being passed up for a job, or actual violence, as extreme as actual violence against a person, including actual, killing or murder. Anyone who has experienced an emotionally painful, sudden, and uncontrollable racist encounter is at risk of suffering race-based traumatic stress injury. And in the US, the term BIPOC, Black and Indigenous People of Color, is becoming more accepted and a more prevalently used term to describe like people of color, and not just looping everybody in together, because while people of color, including like Latinx, Asian groups, do experience racial trauma, Black and Indigenous people have a different experience when it comes to those issues. And so we want to be able to understand that, all of these groups have these issues and experience these issues, but there are some forms of this trauma that is enacted upon other groups much more severely and has a much different historical context. Okay, so in the US, Black and Indigenous people of color are the most vulnerable to this system. All right, so everyday effects of racial trauma. So of course, this is not an all-encompassing list, but hypervigilance, educational anxiety, increased sensitivity and reactivity, negative perception of white people. And this is one I think is really hard for people to understand, because one of the most prevalent phrases that comes like, I haven't personally done anything. I haven't personally been racist. And so it's hard for people to comprehend and understand why someone may look at them and say, I don't trust you, or I don't like you because you're white. So that's hard for people to understand, understanding that this is based on centuries of continued distress and trauma against people who look like me by people who look like them. And so it's an overarching kind of umbrella of trauma that is not specific to just one person. And that part is hard for people to understand. Just to give an example of like the educational anxiety, increased sensitivity and anxiety, feeling distracted, kind of all of these things at once. I remember this is an example, personal story. I remember being in my PhD program, maybe 3rd or 4th year. I can't remember the exact year where I was, but I remember when the Mike Brown shooting. Do people remember the Mike Brown shooting? When that happened? Anybody remember that? Okay. Uh-oh.
I'm just checking the chat box to see. Yes, we have a couple people who said yes, they
Okay.
remember.
Awesome. Okay. So when that happened, I could not focus. I could not think about anything other than how people are treated in this country who look like me, the pain, the fear, and the remembrance of all of the experiences that have happened, all of the things that continue to happen, and things that we don't even see, things that have not been caught on camera. For every encounter that we see on camera, there are probably dozens more that are not caught on camera. Okay? We all know stories, like as Black people, we all have stories. Most of us know stories of a family member who was treated similarly. And those stories, all of those stories flood in. Okay? All of those memories flood in those moments. Okay? So we're not just carrying that particular moment, it's an emotional response to the history that also encompasses that. Okay? All right. Okay. So according to the National Mental Health America, racialized trauma can come directly from other people or can be experienced within a wider system. Okay. So we're talking about policies, institutional violence that happens. It can come as a result of a direct experience where racism is enacted on you vicariously, such as where you see videos of other people facing racism and or transmitted intergenerationally. So this can come in any and all of these forms for any one person. Okay. So I have a question for the group. I'm gonna go off script for a second. This is the question that I posed to my students when I would teach about race and racial trauma and violence. When you think about racism in America, when you think about just kind of going back in our minds, what happened the day after the Emancipation Proclamation? Like really, like think about what happened the day after the Emancipation Proclamation. And I'm looking at the chat to see if anything comes up. Okay, can't guess. Very little changed. Nothing. Exactly. Thank you. Thank you. So nothing happened. Okay. So oftentimes we hear this narrative of it's been 400 years, which first of all, no, it hasn't. It absolutely hasn't. It's only been about 150 or so. I can't count. 60. But nothing happened after that. It was still another 2 years before the last enslaved people were freed. What happened after that? We are now, people are freed. What happened after that? What came next? After the last enslaved people were actually freed, so there are not slaves anymore. What came next? And so the purpose of why I'm asking you all this is because one of the reasons people don't understand why racial trauma is still so pervasive is because we don't think about how we got here. We don't think about what has actually happened. We only think about what we think it should be, and not we, but what white people think it should be, or what they think it is based on their own narrative. Okay? So that's why I want us now to really think about like what happened since then. Jim Crow, yes. We had the Reconstruction period, sharecropping, which was just another form of slavery. So Juneteenth was the celebration of when the last enslaved people were freed on June 19th, 1965. 1865, excuse me. So even after that, but yes, Reconstruction happened, sharecropping happened. So another form of slavery, which they were paid, but not actually given the 40 acres and a meal that were promised. Okay, so having to figure out how to survive. Now you you aren't enslaved anymore, but you also don't have the resources that you need to survive. Okay, so then we come into Jim Crow, which was a whole nother period of racial violence, racial oppression, et cetera, et cetera. Okay, and so that's why as we're having these conversations, really think about at what point America actually made things better as a country. Okay, not where Black people made people do better, but where America actually stepped up and did something different. All right. Okay, we can go to the next slide. We can go to the next slide, Susan. All right. So when we talk about different types of traumatic experiences, talked about the direct trauma that people face, where it's, you know, being followed in the store, being stopped by the police for no reason, being called a racial slur, being denied access to an institution, being denied services of some sort. Okay, so those are direct experiences that, you know, an individual person has when interacting with another person or within the system. Okay. Then we have vicarious trauma, where you are seeing, you're viewing, or have knowledge of. And excuse me, the reason why viewing or having knowledge of is there, like when the George Floyd situation became public, I stopped watching these videos years ago. But just knowing that it happened, I don't have to see it to know that it was bad. I don't have to see the whole video. I don't have to watch this man dying to know that it was bad. But the pictures and reading the story was enough to have an impact. Okay. So violence against others in your community, seeing people be deported or displaced, like that's another way that people experience that trauma. So we're talking about immigrants, and like that's a traumatic experience to see one of your family members or someone you know or someone like you knowing that it could happen to you or your family members. Knowledge of societal homicide persons in racial group. Okay. Migration away from the South, housing income disparity in migrated areas. Yes, still waiting for change. Absolutely, absolutely. Thank you. All right. And so then the last one is that generationally transmitted trauma, transfer from one generation to the next, leading to that stress. So talk about the effects of chattel slavery and Jim Crow, Native genocide. Like we just had in Indigenous Peoples Day, which, you know, is kind of a counter to this idea that someone else discovered a land that people were already living on. And so there's still lots of effects, lots of challenges that Native people are experiencing on their homeland. And that's something like we will never even fully understand it because we don't even have the ability to see Native people as often because they've been put into these pockets of land. Okay. Holocaust, exposure and continued exposure to racism. Okay. So all of these issues have impacts. They have long-standing, long-term impacts on our health, on our well-being, on our mental health. So I'm going to talk briefly about this because I'm not a medical doctor. I'm not going to go into details on this, but there's a lot of research coming out that talks about epigenetics and the effects of the trauma, like the physical effects on the trauma. It doesn't change our DNA and our genes specifically, but it can impact how our genes, like the gene activity. So I won't get into that because that is not my lane, but there is a lot of information that is coming out to explain and talk about how generational issues and genetic like passing down of genes can affect our mental and physical health. Right? Okay, so I'm gonna kind of briefly go through these different issues, trying to look at the time. So medical trauma, there's a long history of Black and Indigenous people being used for medical experimentation without consent. People who are property can't consent anyway, but also being, even when they weren't necessarily property, being still experimented on and forced to participate in experiments or being deceived to do so. So like the Tuskegee experiment, that there's a misconception that they gave them syphilis, but no, they already had syphilis and they did not give them proper treatment in order to, misplaced identity, in order to, you know, test on them, okay? Henrietta Lacks, used for cancer research. Her body cells being used for research, and they are still being used today. Black women being used for gynecological research. Dr. James Sims is supposedly the father of gynecology, but a lot of his research came from using the bodies of Black women without their permission. Okay? There is a belief right now in the medical field with nurses and doctors, these are actual situations that happen, belief that Black people have higher pain tolerance and could withstand surgeries or withstand procedures, or wait longer because we have higher pain tolerance, genetically higher pain tolerance. And so either withheld and not given anesthesia, or there's a perception that they only want the drugs for like addictive reasons or addiction reasons. Okay, and so concerns can often be ignored. I don't know how many of you are familiar with Serena Williams' story about how she almost died in childbirth because the doctors wouldn't listen to her, and there are countless other stories. I was actually doing some research on this topic, and there are countless other stories about how women are not being listened to. We know that the mortality rate for Black women is higher, much higher than white women as well, in terms of being pregnant and giving birth. So there's still so many issues in the medical field, and there are still biases and beliefs that contribute to how Black people are treated when they go to the hospital. Which, if we have this history, how likely are people to trust and want to go see doctors? Probably not very trusting. Yep. So, oh yeah, somebody commented Serena Williams' experience. Exactly. So many others. All right, so there is a video in here, but I'm not sure how sound is gonna work with all of that. So I'm not gonna play the video, but Susan, will the slides be given? Will they be able to be accessed later?
Yes, they will.
Okay, so I do encourage you to check out that video. It's about a 5-6 minute video. I cut off the end because at the end he's selling something, but we're not gonna worry about that. So I would encourage people to take a look at that video and just kind of think about the statistics and the information that he's sharing. He's basically saying everything I'm just saying, but in more medical terms. All right. Go to the next one. All right, so next up, we're going to talk about education and experiences in education.
I apologize, Shaquinta. If you'll give me just a moment, my clicks have gotten ahead of me and my computer gave me some kind of alert, so just bear with me while I catch up.
No problem. While she's doing that, does anybody have questions or thoughts about what I've said so far? Well, I'll just say hello to the familiar names that I saw, and your clear screens, but no faces. But hi, y'all. Haven't seen people's faces in a while. Hey, Risa. Oh, miss you too. Miss you too, Sherry. Oh, that one isn't even. Oh, is that it? No. Oh, is it making it go through the video? Hey.
Y'all, we are learning together here, real time. Remember those comments about showing grace and being patient? I'm so sorry that I don't know what's going on with my computer, but it just give me one more minute to get this slideshow back under control. It has run away.
It's okay. I can just talk. I can talk, and the information can be there for people later. I have it pulled up right here beside me. Is that okay?
Okay, great.
Okay. So next, I just want to talk about educational trauma, and I know we don't often call it that, but that's what it is. It's negative experiences, painful experiences, traumatic experiences that people have had through the educational system since we've entered it. So on the slide, which y'all will be able to see in a minute, I have a picture of Ruby Bridges. And Ruby Bridges, I believe she was 6 years old, and she's walking down the steps in front of her school, which she was the first child to, you know, or like the kind of the, I don't call her a poster child, but she was the face of desegregation, okay? And so you have this little girl, this little girl, this 6-year-old little girl who is being escorted by U.S. Marshals because they want to make sure that these adults, that all of these people that are standing alongside the walkway, grown people who are primed and ready to scream at this little girl and possibly hurt her. Because in those times, children were not exempt. Children were not exempt from the violence, okay? And so they're having these U.S. Marshals escort her for her safety, okay? Patient would not call 911 because she was afraid the police would shoot her husband. Yes, yes. People don't trust the police for good reason, y'all. I know that we have, you know, a lot of issues about the police, but there are valid reasons and experiences that lead people to acting and reacting the way that we do when it comes to that, okay? So there was research. I'm coming to that. Well, Susan. So research proving that Black people had smaller brains and were intellectually inferior. And one of the arguments were because our brains were so much smaller and we were so inferior that we really needed white people to take care of us. We really needed white people to make sure that we could survive because we couldn't do it on our own. Or, you know, ignoring the fact that we've done it for centuries, you know, whatever. But there was this prevalent belief: we are inferior, and thus white people need to save us and need to teach us how to be better people, to make sure that we can survive. Okay? Blocking students of color from resources like gifted education and programs to support their educational attainment. Prime example. Just last week, no, 2 weeks ago, my nephew was, he transitioned to a new school. He started a new school. He came from a private school where they are pretty advanced in what they do in their programs, okay? The assistant principal told his mom that he had missed the deadline for gifted testing and that they would have to wait to the next year. My mother-in-law is an administrator in the school system, and so she knew that that was not true. So she was able to advocate for my nephew and found out that the deadline had not passed. It was approaching, but it had not passed. But had she not been within that system, that would have been educational resources that he would not have received. And then he probably would have gotten bored in class and not wanted to pay attention. And then he becomes a problem child, a behavioral problem. And now, you see where I'm going? The trajectory, okay? And so these things happen all the time, right? There are assumptions of behavioral issues when students of color enter classrooms already. There's already a belief that they're going to be a problem. And so they're treated as such. And they see that the teacher doesn't care, and so they act as though the teacher doesn't care. And the cycle continues, right? I also have a specialization in disability studies. And what we saw was children are being under-supported and under-tested for things like autism. Because if there's a behavioral issue or challenge, it's because they're intellectually inferior, not because there's some type of maybe an autistic disorder, something of that nature, where some support could be provided and they could actually continue to thrive. Okay? Or an assumption of intellectual inferiority, and thus not actually testing to figure out what else might be happening. They really have a learning disability. And so again, they don't receive the support, they're put into special education. Okay? So there are all these issues that keep Black and brown children from being in educational tracks that help them to thrive. Okay? And so it continues to perpetuate that system of intellectual inferiority, underachievement, and continues the cycle of poverty as well. Okay? So you can go to the next slide. All right, so this is a picture of Ruby Bridges today. This might have been maybe a year ago, but you get the idea. This is her today. She is not some woman who is, you know, much older, you know, ailing health and, you know, not, I don't want to say that. She's not much older. She's 66 years old now. So this was not, you know, centuries ago. This was not that long ago. So think about her peers, both Black and white, and how people who were in her age group, in her peer group, experienced some of the same things she experienced. And for the Black students, and for the white students, how they grew up with some of the same beliefs and biases that come from their parents of she shouldn't be here. Okay? These biases, these thoughts, these feelings, they don't go away overnight. Okay? So these are our parents, some of our peers. She's a little bit older than me, but for some parents and peers. So there's not enough separation between us to be able to say it shouldn't be an issue anymore. Okay. All right. Okay, so with mental health, one of the main issues with mental health is a lot of our diagnostic standards are normed with white people. And so oftentimes we struggle with diagnoses because they are based on homogeneously white samples. Okay? So in some cases, we see people whose valid concerns or valid issues or just whatever they're coming to therapy with can be seen as attention seeking. People aren't free to express certain views and angers because they're afraid that they're going to be invalidated by the therapist. Okay. Less likely to be diagnosed with depression and anxiety because of symptom expression, because it doesn't look like it does in other people. Sadness and anger are not emotions that specifically Black people and people of color have not been historically allowed to express. Like you don't get to be sad. There's not the space for that. Okay, and so one may be depressed, but they don't have the language, or they don't have the language as we've been taught it to express that depression or that anxiety. Okay, it may present as you know, I'm just overwhelmed and I feel like I can't take a rest. Okay, I just don't feel like being bothered with anybody. I just don't like people. Any of those types of things as well. A lot of times clinicians are, or can be, I should say, dismissive of clients' concerns. May say, you know, everyone experiences that, or trying to rationalize away what they're experiencing. What may be another reason this could have happened? And so when we think about like the CBTs, for example, we want to think about alternative possibilities of what may be happening when someone may be experiencing anxiety or having negative thoughts or whatever the case. But that can be extremely invalidating for a person who has experienced some type of racial event, racial trauma. Okay? I have countless peers who are also therapists and friends who have gone to therapy with a very similar experience of they didn't understand. They tried to talk it away. They invalidated what I was saying. And in an effort to, you know, do what you've been taught as a therapist, it may be it may be alienating to the client. Okay? There may be microaggressions in therapy, racist statements that are made, assumptions that are made. The number of clients a number of Black peers who have talked about how a therapist assumes that they came from poverty or that their father wasn't in their life. Like, that is a huge assumption to make. But where does that come from? You know? Okay. So, all right. So in terms of healing racial trauma, we always talk about, like, how do we heal? What do we do? How do we change things? The biggest thing that we can do is acknowledge that it exists and not try to rationalize it away or defend the status quo. But what would you think, and this is a question for the group, what do you think makes that difficult for people to acknowledge that racism exists, that racism is still, you know, we're not getting whipped, but that the mindsets and the beliefs still there? I'm looking at the chat. Guilt. They might be benefiting from the current system. Yup. White privilege is real, but people hate that word. Hard to see water when you're in the sea. Whew. Yeah. And it's hard to see. I like that. I like that. Roger Williams, I don't know you, but I like that. Thank you. Yeah, it is uncomfortable. Any other reasons? Those are good. You have to be honest with yourself and listen, because sometimes you have bias that you're not aware of. Yeah. You have to own your own personal beliefs and biases. Yes, all of these things. They might have to challenge their family. Yes, which is very uncomfortable. Like, having to go up against your family, having to challenge your family, that can be very uncomfortable, because there's always that threat that, you know, if I challenge my family, if I challenge my base, my base of security, then that's very scary. And understandably so. And so it really does take specifically white people to step out of that, step into that discomfort and that fear, and be willing to embrace that in order for things to really change. That's hard. And we know that. But it's also hard to have to walk around wondering, like right now, I'm really transparent with y'all, because I don't believe in tiptoeing around stuff. I don't believe in, you know, making it cute and pretty just because this is a presentation. We're gonna talk, okay? Like, right now, painful to think you may be in a situation you can never get out of fear. Yes. Like, right now, I'll give you an example. The day after George Floyd, I was riding around, or that I found out about George Floyd, let me say that. I was riding around and I just saw a police car sitting somewhere. Like, they're just, you know, waiting, doing what they do, monitoring. And I got terrified. I was terrified. I was just like, what if he, I haven't done anything, not a single thing. I just left my house. I was heading to work. I was heading to a merge. And I was terrified of what could happen in that moment. Because of the current climate, I'm not afraid somebody's gonna call me a racist or be mad at me. I'm scared somebody's gonna come through my door. I'm scared somebody is going to, you know, feel empowered again and, you know, burn a cross. Like, those are real fears. Are they rational? Yeah. But that's what trauma does. We don't tell people who have experienced, you know, other forms of trauma that their fears don't make sense. Because if it's happened before, it makes sense that it could happen again, even if the likelihood of it happening is pretty low. Okay, that's why it's trauma. Okay. But yeah, painful to think you may be in a situation you will never get out of. But yes, like the fear of encountering someone, the fear of someone saying that you did something wrong. When we think about the Jonathan Price situation, who is familiar with the Jonathan Price situation that recently came up? Anybody? I wish I could see y'all. No? Nobody? Nobody familiar with Jonathan Price? Okay. Okay. So yes, Roger. Okay, thank you. What is the name? Jonathan Price. So Jonathan Price was a Black man in Texas recently. I can't remember what town, what part of Texas, but he was a Black man who saw a woman being abused by her partner, and he jumped in to help. He jumped in to help the woman, and the police arrived and killed him. Now this case is a little bit different because he was actually pro-police. So he was Blue Lives Matter supporter. He very much was, you know, back to blue. Like they knew him in the community. This was, I won't get into the like how this was different from like some of the other cases, but he was very well known in the community. So the police officer that killed him was actually charged pretty quickly. Okay, so we didn't have to wait forever and, you know, really fight and advocate for this. But part of the reason, or at least, you know, the belief amongst others, is that part of the reason it was so easy and so quick is because of who he was and his relationship to the community. So for other people who don't necessarily have that, it's not so swift. It's not so quick and easy. But luckily, thankfully, we're on the path to justice for him. But that is not how it happens the majority of times. And I'm gonna keep going, y'all, I promise. Okay, so people often, go to the next slide. People often have the tendency to say things, I'm looking at the comments. I'm still trying to understand how anyone does not see George Floyd and other similar situations are not racism. Just keeping it real. Yeah. Is it fair to say there are two different realities? Oh yeah, definitely. Absolutely, absolutely, absolutely. And so that actually goes to the next point of like, people have the tendency to say things like, you know, I've never experienced it. And because they've never experienced it, then it must not be true. Doctors, teachers, therapists, counselors, I know would never do that. The teachers I know would never do that. But one, you're not a Black person or an Indigenous or a person of color. So of course they're not going to do that to you. You're white. That's issue number one. Other thing is, just because you're not doing it doesn't mean it's not done. There are a lot of things that we know happen, even if they don't happen to us. But racism is just unfathomable. Okay. So we, as a people, for, you know, any oppressed, marginalized group, we have to get out of the I've never seen this, I've never experienced this, or does that really happen? And really start to question and open our minds to the possibility that yes, what this person is saying is true. Why haven't I experienced it? Why haven't I experienced it? But how can I contribute to fixing it? All right. So just to kind of give a few little little tidbits. There's no way that I can fit, everything into this presentation. Like, there's just no way to do that. But just some kind of small things that can be, looked for or considered when, working with people who may have experienced intergenerational trauma or racial trauma of any kind. One is to know that it's a possibility. Just know that pretty much any client that you come into contact with, some people are going to express it differently. Some people are going to have different levels of engagement with the system of racism. There are going to be some Black people that don't even believe it. And that's fine. That's their prerogative. But there are the majority of BIPOCs who have already experienced some level of racial trauma. And so just expect it when coming to your office, your clinic, your whatever it is, your classroom. Okay. So some signs, and these are kind of things that I have seen, experienced, or just kind of known from being Black. Oftentimes people will not go to the doctor. I know a lot of Black people that they say, I'd rather die on my own terms. I go in there, I might not come out because they're not going to treat me right. So you may have like inconsistent medical histories where people like haven't gone to the doctor for long periods of time. And the first thought might be, oh, they don't care about their health. And that's not true. They may. I don't see color. Woo, that's a big one. So I didn't see that a second ago. But yes, not asking questions. And part of it may be like everybody that comes into the hospital is not a doctor. I have a whole PhD, and I have to look at my doctor sometimes and say, what did you just say? What does that mean? Okay. But depending on a person's experiences, they may not feel comfortable saying, I don't understand what you just said, because they might not want to seem as though they don't understand. They might not want to seem like you think they're not smart just because they don't know your lingo. Okay, so that can be a thing. They can want to leave. They can want to get out of there. People who are anxious often have an urgency to leave a situation that they're uncomfortable in. But sometimes that can be perceived as, again, they don't care about their health, or they're disrespectful, or they're difficult. It may be difficult, but the experience is difficult for them. Okay? For many reasons, valid reasons, historical reasons. Well, mental health professionals. For a lot of people, I see other therapists, like they won't tell me anything if the conversation's still surface level. It's because they don't trust you. Plain and simple. They don't trust you. There is a huge distrust of the mental health field. Again, understandably so. All right. Difficulty expressing emotions. For a lot of people, there's still that mentality that we don't get the luxury of emotions. We don't get the luxury of depression. We don't get the luxury of sadness, of anxiety. And that has been passed down for generation to generation, because when our ancestors were in the fields or in the house and had to work, there wasn't no, I need to take a day for my mental health. Excuse? That didn't exist. I'm tired. I don't feel good. I'm sad. That did not exist. And those mindsets have been passed down. There are people my age, my peers, who have never seen their parents cry, who have never cried themselves. Okay. We're talking, suck it up. And that's also a function of poverty. I know that there's some overlapping there, but okay, again, disproportionately higher people of color. Okay. Clients downplaying their needs, shutting down after a comment. That's a huge one. After you make a comment, if you notice that a student, a client, they shut down, that is a key sign that you have offended them, and they may not tell you. All right. All right. So how do we heal racial trauma, overall? And really, it's just providing a different experience. We do not heal racial trauma by pretending that it doesn't exist, by telling people to get over it. Definitely don't. By being colorblind. It is not a thing. And please don't say it. Please stop saying that if you say it. I'm seeing from the comments that people have, different, some levels of understanding here, which is wonderful. But color blindness is not a thing. I don't see color as erasure. And so I want you to see my color. I want you to see that I am Black, which means my experience has been different from yours in probably multiple ways. There may be some similarities, but in trying to find similarities, don't erase my differences. Okay? Be open and curious about people's experiences. Validate their feelings. Because that's what we do. Like, feelings don't have to be facts of what's happening in the moment. The feelings are real. Try not to interject your own beliefs and narratives about their experiences. One of the most invalidating things to do to a person of color, Black, Indigenous person of color, is to say, oh yeah, I experienced something similar to that. And it looked like this. That is the quickest way for me to be like, never mind. I remember when I was a master's student at, in my master's program, my name is Shaquinta. It's Shaquinta. And I struggled with that for a long time because I know that there have been situations where people were like, Shaquinta? No, not her. And I was telling a story about that, and someone interjected and was like, well, my name is Amy. And so I really, I understand what you're saying because my name is Amy. And I was just like, so be careful with that. Even if you belong to another marginalized group or oppressed group, whether it's LGBTQ issues, disabled issues, I'm trying to think of other religious issues, any other area of discrimination. Remember, women's issues. Women are the most struggled in that area. A lot of times, I'm going to call a thing a thing, white women feel that because they're women, that they can understand the struggle of Black people, forgetting that they're also Black women. Black women exist too. Okay? So just being careful about those types of things. Educating yourselves on the disparities. Okay? Asking yourself how you know what you know. Where did that information come from? What made you think that? Is this true? How is it true? Right? Really coming from a curious place, really coming from a place of wanting to learn. Okay. Am I doing on time? Okay. I'm going to be wrapping up. So the biggest thing is, how you, in terms of like racism and being an ally, healing trauma, how you respond is what determines whether you are falling to the racist and a trustworthy category or whether you become an ally. There is no neutral. There is no neutral. And so if hearing the word racist, being called racist is more important to you, or not being called racist is more important to you than trying to understand and deconstructing the system of racism, then it's a self-fulfilling prophecy, if you will. Okay. And then I just put in some different tips and things for each kind of sector, so to be medical professionals, therapists, and educators here. So I just put some pieces in for each group. But I want to see if there are any questions from anyone.
Shaquinta, thank you so much. And I don't know if you have more slides, but you asked for questions, and as always, I have a list.
Yes, I did want to go ahead and answer some questions. There are some list tips and things in the slides for when people get them. There's just some things that you can do in your offices and some resources. So yeah, I would rather do some questions.
Okay. So what I heard you describe today with tidbits from history, as well as from your personal life, and please tell me if this is accurate. racial trauma is not necessarily a single instance. Like oftentimes when we think of trauma, we might think of a car wreck, for example. But racial trauma is really a process. Also, it seems like it doesn't have to be one that you individually experience, but one that happened to another person of color for you to feel that impact. And while that may seem obvious, I hadn't thought of it that way.
Yes, yes. So I'll give you an example. So there was I was at a conference a few years back, and it was right around, like right after the Trayvon Martin incident. And a researcher had done some research with young Black boys relating to trauma. And that was not the focus of the research, but she did a trauma timeline with the young men, and they ranged from ages, I think maybe 10 to 17. And on their trauma timelines for several of the young men was the Trayvon Martin shooting. So even though that was not even a question in her study, but because it had happened while they were in adolescence, it was highlighted as a traumatic experience for them. Because for us, when we see these incidents, there is nothing separating us from that other person. And that's the thing that people don't understand. There's nothing, other than location, which that's not a separator, because guess what? There are police everywhere. There's nothing separating me from Sandra Bland or Breonna Taylor. Okay. And there are a lot of other women as well. Okay.
So, Shaquinta, by the way, Toya has put your email in the chat, buildingbridgesft@gmail.com. One other thing that I wanted to ask, clinician to clinician.
Yes.
So if I, as a white clinician, am working with a client of color, if race doesn't come up, what is the danger of not at least acknowledging it?
So the danger of not acknowledging it. So there are there's two camps in terms of even Black therapists, are in one of two camps. One is you should bring it up at the beginning, make it a thing, bring it into the therapy room. I'm a white therapist, you're a Black man or woman, how does that make you feel? And then there are some that say don't stray away from it when it comes up, but it doesn't have to be the topic of conversation if it's not the topic of conversation. So it depends on which camp or which philosophy you fall into. I would say if it comes up, don't shy away from it. But a way that you can even let clients know that your therapy room is a safe, or your camera is a safe space to talk about it, is to introduce the conversation and say, hey, I know there's a lot going on right now racially, and I just wanted to, if this is something that you want to talk about, I just want you to know that the space is here for us to discuss what is happening with that. Okay. So it doesn't have to be like, hey, let's talk about this. But you can signal to your clients that I recognize that this is a thing, and I am perfectly okay with us talking about this.
So Shaquinta, Roger, who has commented a couple times, he's the one that said if you're in the water, you can't see the sea, or vice versa. I'm gonna have to go back and copy that because it was really good. He opened our event this morning and presented. He's the executive director of Spartanburg Area Mental Health. He says, we encourage all staff here to at least bring up the topic. If you don't raise it, the message is that it's not permitted. I know what I try to do is when I'm capturing their background information, tell me about your family, tell me about your life, tell me what are your spiritual beliefs, is to incorporate that piece right there so that
Mhm.
that gives me some sense of comfort level, and
Mhm.
also their opportunity to talk about it more.
Mhm.
But I just wondered about, in this day and age, when racial trauma can come from any newscast,
Yeah.
you know, being sensitive to that. I guess I just hadn't really thought about it like that until you talked about it today.
Mhm. Yeah, people are thinking about it, and people are thinking about it from different perspectives. Like, there's some people who are like, I'm tired. I don't want to talk about it anymore. And
Mm-hmm.
so that's why I say, like, it doesn't have to be a conversation, because it doesn't have to be a conversation, but it can be introduced, or it can be, the space can be open. But we also don't want to force people to talk about it, because racial battle fatigue is also a thing. Okay. And so many people are tired of talking about it, but then there are some who really do want to process it, and have a space to just let it out. So I work primarily, I have some white clients, but a lot of my client base is Black. And how much we talk about the things that have been going on, specifically, is probably this much in comparison just to their identities in general, and experiences in general. But yeah, so if you have any other questions, please feel free to message me, email me. I love talking about this. But if you're going to talk about it, just make sure that you're comfortable talking about it. Don't bring it up if you can't engage in the conversation in a meaningful way. That would be my thing.
Okay, awesome. Well, thank you so much. We have actually gone over time. So no, it's an important, a really, really important topic, and I thank you for sharing both your personal and professional experiences with us. So at this time, we do have just about a 6-minute break before our next presenter. And at this time, I would invite everyone to put your name and your licensing requirements. For example, mine is Susan Lee, LMFT, in the chat box, because we will use that to verify attendance for the purpose of CEUs if that is needed. So please take time, type your name and your letters in the chat. We will reconvene at 2:10 for self-care while caring for others in a COVID-19 world with Carson Rogers. right. We have made it through most of the day. And again, I want to thank everybody for joining us for the 5th Annual Mental Health America Symposium in this new format. I would like to thank Spartanburg Regional Healthcare System, in particular, Nelda Hope and Toya Hancock, who have been instrumental in today's events, as well as Vanessa Thompson. They're all with Spartanburg Regional Healthcare System. I would like to thank the Mental Health America Advisory Board. Mary Miles, the advisory board chair, will be speaking right after this presentation. And so she'll share a little bit of information. Also, she'll be drawing for 2 $25 off certificates for registration for next year's Mental Health Symposium. At this time, we are going to have Carson Rogerson present on self-care while caring for others in a COVID-19 world. And if you'll bear with me, I am going to pull up the appropriate bio. As a reminder, if you haven't already put your name and license in the chat, please do so at this time. If we need to verify for CEU credit, that is how we will do it. So Carson Rogerson is a South Carolina native who was born in Florence and grew up in Georgetown. He is a graduate of the University of South Carolina. I guess I'm supposed to say the year because it's in there, 1979, in Columbia, South Carolina, and SEBTS 1984 in Wake Forest, North Carolina. He also completed the coursework for an educational specialist degree in marriage and family at USC in the 90s before redirecting to clinical spiritual care. He has served in the role of pastor for churches in North Carolina, South Carolina, and in the Middle East, specifically East Jerusalem and Dubai, United Arab Emirates. He was in Palestine and Dubai from 1986 to 1992, working with Arabic-speaking persons supporting hunger relief and student work. Endorsed as a chaplain and CPE clinical educator by the Alliance of Baptists, he was certified as an ACPE Associate Supervisor in 2004. Carson was a chaplain pastoral educator at Palmetto Health, primarily the Richland campus, for 6 years before coming to Spartanburg Regional in April of 2006. Carson serves on the Southeast Regional ACPE Board and Certification Committee. He is a board-certified chaplain through the Association of Professional Chaplains and is a certified ACPE supervisor. Carson has 5 children and enjoys working out, camping, collecting Persian rugs and ancient coins, college sports, and spending time with his family. So at this time, I would like to invite Carson to join us. And if you'll just bear with me a few moments while we get Carson situated. Let's see. There you are, Carson. Carson, are you unmuted?
I am.
Okay, welcome and thank you for joining us today.
Thank you, Susan. I appreciate the invitation. Look forward to being with you. Now, will you put up the screen or will I do? Okay, good.
I think I have it, but sometimes that is questionable.
Yeah, it looks
So
like you got it. Yeah. And so to change, I'm going to just hit the X. Do I have to hit something else to get?
Just put it in the chat directly to me.
Okay. Let me see. Okay, I see it. All right. And I don't see your name on here. Oh, there it is. Okay. Gotcha. All right. Well, thank you for the introduction, Susan. I'm glad to be with you. I've been here in Spartanburg for 14 and a half years as the director of spiritual care and an educational program for spiritual caregivers, and love Spartanburg and plan on retiring here. During this presentation, I'm hoping to just give you a brief summary of what to do in giving self-care, giving yourself self-care, and caring for others at the same time. So I'm going to ask her to check. Okay, it might take me a second to figure this out, but if you'd change the screen, Susan. All right. So what I'm hoping to do is to acknowledge that all of us for a long time have been under a high level of stress, and I think that's something we bargained for. We have empathic natures which draw us to the kinds of vocations that we're in, whether it's what you're doing in mental health, or what I'm doing in hospital health care. It requires a lot of compassion, but it's gotten worse, as you've probably recognized in the last year and longer. It seems like with COVID and other new experiences in life, that we're all operating with a great deal of pressure and struggle. So we want to see how we can take care of that and care for each other. Do I just send? Okay, gotcha. All right. You might have seen this article, which I think just also ratifies what we're feeling in anxiety. But it was by the Washington Post, saying that 1/3 of Americans are showing signs of clinical depression, anxiety, which is, I guess, the most definitive and alarming sign of the psychological toll that's being exacted by the corona pandemic. Those are with every group of ethnicity and color and culture. But you might notice from this screen that it's a bit higher for Hispanic, Latino, Black, and then other ethnicities. And I think we can understand some of that reasoning too, as was talked about earlier. And I hope you recognize that in your clients and in the people you care for. All right. Am I getting to you? Oh, I see. I've got to do it again. All right. Trying to get into the rhythm of changing the screen. So compassion fatigue. What is it? It is the natural behavior and emotion that arises when we are either in a situation where somebody we care about, whether it's a client or a family member, is experiencing a traumatizing event, and that part of us that is empathic, wanting to offer help or wanting to be with the traumatized person, whatever they're facing. Compassion fatigue is also, it goes by several other names, but the more frequently referenced name is vicarious traumatization or secondary traumatization. And that also is that emotional residue or the strain of exposure to working with those who are suffering from the consequences of traumatic events. It can be due to one specific event, or it could be an event that is piled on by several similar kinds of cumulative levels of trauma. All right. Compassion fatigue symptoms. You're probably aware of them. They could be mental, emotional, spiritual, or physical fatigue. Sleep disturbances. Some people sleep and can't seem to wake up or get up, and then others can't sleep at all, and both of those are not very healthy. Anxiety, irritability, anger, depression, reduced or increased appetite, high blood pressure, dizziness, guilt, all of these are impacting our ability to concentrate or to attend to tasks. Triggers. What are the triggers? I mentioned it could be a single exposure to a traumatic event, and often that is the case when it is a situation that reminds us of some incident in our own life or some relationship in our own life. But it also could be a cumulative set of exposures to folks who are going through difficult times, emotionally, spiritually, physically. And so it could be cumulative deep traumas. Those bring about experiences of deep sadness, pain, death, loss. And another trigger would be us not being able to separate ourselves when we are engrossed in what other people are feeling. It's really easy for an empath to relate in such a way that we don't recognize the boundary of that's this person and we are a different person, so that we can maintain a helpful position without absorbing it to the point that we too become traumatized. And the other issue that we have to be careful of is make sure that we have sufficient resources. So compassion satisfaction is the, I guess, the balancing of those experiences. It is the way that we are able to continue to feel that sense of satisfaction or pleasure that comes from helping. It's that intrinsic good feeling of knowing that we've made a difference in the life of someone else. We've been able to offer something positive in the welfare of another. And that actually does alleviate some of that fatigue in the work that we do that can create compassion fatigue. So it mitigates those things. It also enhances our own sense of well-being. I don't know if you've ever left at the end of the day and just felt like, oh my goodness sake, I love my job. It's because you've had that experience of compassion satisfaction. And then the high potential among all of us who are in healthcare of any kind, whether it's mental health or physical health, to exhibit that significant compassion satisfaction with our chosen profession. So what are the symptoms? Obvious ones are your, happiness, joy, contentment, balance within your life, and that work-life balance, creativity, and productivity. Things that you feel that make you feel satisfied and happy that you're doing what you're doing. All right. So what is the difference between compassion fatigue or burnout? I think a lot of times it's how long you've had the compassion fatigue without tending to that. Burnout comes when you have not, you've been dealing with it for a period of time, or it's something that hits you all of a sudden and it just seems to paralyze you. Compassion fatigue obviously will be dealt with when you're able to acknowledge it and tend to it, and your recovery is going to be quicker than it would be if you were experiencing burnout. Okay, switch. So burnout is a syndrome of emotional exhaustion, deeper personalization toward patients, and a reduced sense of personal and professional accomplishment. It is what causes us to withdraw emotionally. It's a real fine line. It's like walking a tightrope when we're caring for people, because we either go too far and fall off on one side of caring too much and we go down with the ship, or we withdraw. And so how do you find that middle ground where you can express compassion but not let it pull you down, and know how to draw that line at the end of the day that acknowledges that you've felt another person's pain, but that you're not going to take home with you and dwell on. And sometimes that takes you by surprise, but it is something that once you become aware of, you need to try to give of yourself as much as you can, and then have that internal boundary so that you won't get into that position. And it's a horrible feeling. You feel like you failed at your profession, you've failed at doing what you want to do to care for people, and it often ends in a change of jobs. So what are the symptoms? I mentioned some of them already: emotional exhaustion, apathy, that withdrawal, that lack of interest. Just don't have it within your being to continue to care and to offer the empathy. Sometimes it creates an anger. You might even snap at one of your folks that you're trying to help because you just don't have it in you, and that irritability that comes with that as well. So triggers, insufficient resources. You might not have enough help. You might feel overwhelmed, and most of us do on any given day. You might feel like you're not getting, the financial the pay that you need, benefits. Might not feel affirmed in your job by the organization, poor boundaries, or just don't feel like you're getting the kind of skill development that you need. Things like what you're doing today. So what we know is that compassion fatigue affects a multitude of folks like you and like me who are giving care in whatever that environment might be. And we know that pre-COVID, before COVID, that 90% of the critical care nurses and folks like you that are dealing with trauma day in and day out are going to experience compassion fatigue as a normal result of your work. It's what you do with it that makes the difference. And then what we know too is that family caregivers, those that are maybe not experiencing the illness, the mental illness or the physical illness, but they're caring for somebody who is in that situation, also could experience compassion fatigue. But now with the COVID-19 world, there's been an increased economic anxiety and fear and depression for caregivers and families. And then you add to that political and economic issues. We just are so divided, as you are fully aware. And I don't know about you, but I have to limit how much news I can watch. It just becomes terribly troubling. And yet I know I can't act like it's not happening. So I have to look and switch. So what are some emotional support strategies, especially now with COVID? One of the things that I think could be really helpful, I don't know what each of your positions are, but if you could try to just be intentional about encouraging your staff and offering messages to your colleagues that are going to highlight their contributions. It's amazing how much good that can do. Intermount Health created a caregiver going home checklist, and I love it. It invites the caregivers, people who are doing the kind of work that you and I do, to, at the end of the day, just reflect on what you've done and then start preparing for the transition to, you might be in your home doing your work, but preparing for that transition to your home and your family or your whatever it is that you're going to do after your difficult shift. And so these are 5 things that you can maybe put into your daily way of going from transitioning from work to home. Acknowledge something, one thing that was difficult about your day, and then in your mind, packing it up and putting it aside and letting it go. Then consider 3 things that went well in that day. Be proud of the care you gave. Think and celebrate that within yourself. If you're someone who is managing other people, check on your colleagues before you leave. Do they need to debrief? Are you okay? Do you need to debrief? Do you need to talk to your colleagues or leaders for support? and then now make a cognitive switch to attend to home. You know, for those of you who are in healthcare, you know, that might mean shower, rest, recharge, do something that helps you to restore your depleted energy. Can you switch? Okay. Emotional support. Find space to debrief and recharge. Here at the hospital, we've started something I really like, and it can be adjusted to whatever your field is. But we have something called battle buddies, and our nurses, who are especially on the hot floors, those frontline folks who are dealing with very, very sick people, they check in with each other 3, 4, 5 times a week, and just check in and say, you know, what's going on? How are you dealing with what you're faced with every day? And what are some things that I can do to be of support? How can I be a listening ear? Those kind of things. And in your organization, you might be able to use EAP counselors. Even if you are a counselor, we need counselors. You have colleagues that might be able to be good listeners. Here we have a quiet room. We have a chapel where people can get away for a little bit and reflect and meditate. What kind of resilience resources do you have? A place for meditation or fitness or yoga, or facilities to shower and change before going home, especially those who are encountering COVID. Facilitated support groups, peer or professionally led, and then access to your own mental health support. You know, how do you find help for the things that you need? So the summary of what I've said so far is we are going to be prone to compassion fatigue, and that's the hard thing about caring, that thing that drains us. And then the good thing is we have compassion satisfaction that can balance that out. It's a feeling of altruism, of self-confidence and self-awareness that we're making a difference in somebody's life. And we talked about the negative aspect of caring, you know, the two aspects of secondary trauma or burnout that can not only wear you down, but it can cost you your vocation. So did everyone get the professional quality of life inventory and get to fill that out?
That was sent out in advance, but also it was posted in the chat just prior to your session.
Gotcha. Thank you very much, Susan. So you've had the opportunity to do that. You may have probably, if you've already done it, you've recognized you're somewhere in the middle range, and that's okay. Not many people are going to be low on the areas of compassion fatigue or burnout. But you know, you want to make sure that you're building that area of compassion satisfaction. We're going to talk a little bit about how you might do that. So keep that, and just every now and then, just follow the directions and do the calculations and check in when you're feeling low. It's not a medical test. It's really just an inventory. It's not a psychological test. It's really just for you to kind of check in with yourself to see how you're doing. And I find it helpful. I did it a couple of weeks ago. I've got some new students, or a month ago maybe now, and I let them do it after a couple of months of being in the position of spiritual care at the hospital. And most of them were still doing pretty well, despite all of the changes and the craziness going on right now. And I did it too, and I found that I was more stressed than I realized. And so I started doing some things that I'm going to now talk about that will hopefully help you a little bit as you make those changes. Let me keep going through this. Sometimes I have enough time to go through it and have a little bit of conversation between folks, but we're not going to try to do that now since we're pressed for time. So if you can look at this, I think it might have been in the paperwork, but look at this if you think that would help you in filling it out again. And it's something you don't think too much about. You just kind of go by whatever you're thinking and consider the last 30 days. So I want to talk about resilience. It's something that we all have to some measure, and it depends on the situation, whether or not we're as resilient as the average, or less resilient, or more resilient. And we talk about I want to talk about a little bit about the gift of limits, recognizing what our limits are. What are the areas that are triggers for us? Can be really, really important. You know, we've often heard that that argument between what gives us our personalities. Is it nature or is it nurture? Well, it's both. I mean, there's enough evidence that nature and nurture contribute to who we are. And I was writing a paper many years ago, and I started thinking, it is not just nature or nurture. It's also choice. And I think a lot of the work of folks who do therapy and things like choice theory or similar kinds of approaches recognize that there is a third, maybe even more important element in what gives us resilience, and that's the ability to make choices and to change the direction of our behavior and our being able to look at a situation. A lot of theories talk about the fact that it's really not that traumatic event as much as it is our interpretation of that event. And so I hope that you can, when you find yourself in that you can think in terms of, how am I thinking about what I've experienced, and how can I refocus to something that would be a little bit more positive. So a simple practice that that I want to talk about now is the practice of gratitude. Gratitude. I think I went one too far. Can you go back one? Maybe I did. No, I didn't. I'm sorry. Go forward. So the practice of gratitude. I started doing this. I went through a period about a month ago that I was watching way too much television and seeing too much about the COVID numbers, and also looking at the news and getting overwhelmed with some of that. And a friend of mine said, "Why don't you do this? Focus on gratitude." So I looked up some techniques, and I found one in this website, greatergood@berkeley.edu, and gave me some ideas. And I started doing that. I started at the end of my night. I would get a pad out by my bed, and I would first of all acknowledge whatever it is that has me kind of in a spin. And then I started writing out 3 to 5 areas in which I was grateful. And it might have been a person, it might have been an event, it might have been the fact that I have a roof over my head and I have food on the table, and those kind of things. And so after I started doing that and just kind of thinking about those and letting myself feel gratitude for those things, about a week later, I started realizing that fog was lifting, and I didn't feel nearly as helpless or hopeless or afraid or anxious. I've never had an anxiety attack, but that week before I started doing that, I thought, I wonder if that's what one feels like. It was this just feeling in the middle of my chest, like I don't know if I can breathe. And fortunately, it didn't last long, and it wasn't as scary as I've heard other people talk about it, but it really did help. So gratitude can be helpful physically. It can help you to develop a stronger immune system. It can help you become less bothered by aches and pains, lower your blood pressure. That, in addition to being more motivated to exercise more and take better care of your health and sleep longer, and feel more refreshed when you're waking. I'm at the point now, partly because I am tired at the end of the day and giving, that I'm going to bed at 9:30, whether I'm done with whatever I need to do or not. And I've been amazed at how much better I feel and how much better my sleep is, the quality of my sleep. And I really do attribute it to this new practice of gratitude. Gratitude is also known to give a psychological boost. It gives you a higher level of positive emotions and all of the chemicals in your brain that need to be flowing. More alert, more alive and awake, more joy and pleasure and optimism and happiness. It definitely improves social connection. And I said connection with an extra C, I guess, because I got a little bit choked up. I misspelled it, but I think you know what I'm talking about. When I am feeling like I'm doing work that's making a difference, and I'm grateful for that work, and I'm grateful for my colleagues, I feel a connection, and it feels more helpful and generous and compassionate, and I feel more outgoing and more forgiving and less on edge. I feel less lonely and isolated. And every now and then it kind of sneaks in, and then I remember how grateful I am for my colleagues and for my work and for the fact that we're helping people get better and that we're helping people who are not going to survive to make a transition that is not, that hopefully is smooth and not so difficult. So the gift of self-care is the discipline of attending to whatever those physical, emotional, spiritual, mental needs are that you have, to tend to those and give yourself room to do whatever it is that you know regenerates life in you, whatever activities, behaviors which will allow you to experience renewal and growth. And that's from a dear friend of mine, Teresa Snorton. Another one is self-care is a philosophical and theological statement about oneself and one's life. I think that's so true. And that too is a dear friend of mine who said that. So self-care, it helps you to alleviate those symptoms of compassion fatigue. And if you can develop a daily discipline of attending to your own physical, emotional, spiritual needs, that will allow you to experience some healing and renewal and growth, it can be extremely helpful in days like this. And we're going to talk more specifically about what that looks like. But I want to let you know that it is your responsibility, but it also can be aided by your family, by your colleagues, and by the institution that you work with. And so recognizing that, whether you're in a management level or not, helps you to kind of talk about what it is you need in each of those areas of your life. So what are components of good self-care? Well, I think there are probably three. We think about the trichotomy of Greek thinking, mind, body, spirit, but they're all interrelated. We are a unity. We are not separate parts that just kind of happen to whatever happens to us in one of these areas impacts the other areas, and we're seeing that with our patients who come in. And so that's why we offer holistic care. It involves the physical, the medical, but also the mental, the spiritual, and the emotional. All of those are very, very important. And if you let those work together, you have a much better opportunity to have good self-care. Some of the elements, what is well-being? Some of the elements include a positive self-concept, and the ability to locate and and enter into those things that give meaning and purpose in your life. Good physical health, and we're going to talk a little bit about that in a minute, and good emotional adjustment. So wellness, and this is the nurse anesthetist group. Wellness is a positive state of mind, body, and spirit, reflecting a balance of effective adaptation, resilience, and coping mechanisms in personal and professional environments that enhance the quality of life. I think that's a really good definition. What we all want. What is physical well-being? A state of physical well-being is not just the absence of disease, it's also making those behavioral lifestyle choices that are going to ensure your health and avoid presentable diseases and conditions, and to find a way to live in a balanced state of body, mind, and spirit. Some of the evidence-based physical practices, and listen, I know that not everyone is going to be drawn to some of these. Some of these I'm not drawn to either, but find what it is that allows you to get out and move and acknowledge your body and be aware of what's going on inside of your body and talk about it and to address it. But for me, massage, which I have not had in about 8 months, is about to kill me, is at the top of my list. It relieves stress, lowers blood pressure. Similarly, reflexology, it can be other parts of that field, whatever you've done, and that to me is amazing as well. Yoga, I was doing that 2 or 3 times a week before, and I just don't like the idea of being in a closed area, so haven't done that as much. But you can get that on YouTube and other places if you don't have a place you can go to. And some of the centers now, some of the gyms are offering that as a part of the package as well. But anything that helps you to become more aware of your physical body and what's going on, and make peace with your body. So other things, exercise, diet, there's so many diets out there, and some of them are just create a rebound effect. Some of them are cutting back on portions, going to a vegetarian, a vegan diet. Whatever works best for you and your body, try to do that. And try to stay with something. Don't pick something that's going to be really, really dramatic, and then as soon as you stop that, and usually a lot of those diets that focus on protein and cutting everything else out can be actually counterproductive. And then things like aromatherapy. I've started doing that not only because of the sensory effect, but I think physically, I think just breathing in some of those scents is a good thing. But whatever works best for you, rather than what somebody else is saying you should do. So mental well-being, that describes, how you're feeling and how you're expressing those feelings and how well you're coping with day-to-day life. It's associated with a sense of self, an ability to adapt to change, and to positive self-regard. Evidence-based mental practices include cognitive restructuring or reframing, and if you're a therapist, you're probably already keen on that and doing that. But basically, again, to just think differently than your first response to a situation, allowing yourself to reframe what might have happened this week or some other time in a way that does not pull you into that spiraling down effect. Reflection, and that could come in a lot of different ways, but allow yourself to reconsider or consider a situation in light of whatever your values, beliefs, culture, and experience might be telling you. Journaling. I was a journalist major in college for my undergrad, and it's something I can't stand to do. I don't know what it is. I write a lot anyway. I guess that might be it. But A lot of people I know and really respect do daily journaling, and it helps them to get it out. Whatever, talking about it, whatever way you can get that out, emote and let yourself feel and address it. You know this because of your practice in your field, but you cannot keep packing away things thinking that they'll just disappear. They just continue to build until you feel covered up by them. So don't do that. And then skill development, things like, again, what we're doing here is really important. Emotional well-being. Obviously, you know this, increased emotional well-being is indicated with enhanced coping ability, positive self-esteem, positive self-regard, performance and productivity, and possibly longevity, life longevity, or work longevity. So mindfulness is a bridge to focus conscious attention on the right here and the right now. I don't know if you've read much of Kabat-Zinn, but he says the awareness that arises from paying attention on purpose in the present moment without judgment, non-judgmentally. All right. Evidence-based emotional practices, emote, let yourself feel all of the feelings, happy, excited, tender, sad, whatever it is, let yourself feel it, acknowledge it, and then move on. And that's really, really important. Debriefing, finding somebody that you can talk to in the moment, and just talk about what you're experiencing and what you're feeling. Somebody who's safe, somebody who will listen and not try to fix. And somebody who will be able to give you feedback. In the hospital, sometimes we see things that, and I'm sure you do in mental health too, you see things and you might have somebody you can trust to keep confidence and tell them about it. And they look at you with these eyes wide open like, I don't know what to say. Find somebody who is a colleague who does know what to say and can resonate with you. Talk therapy, art therapy, whatever social connections you have, music therapy or therapeutic music. Sometimes it doesn't have to be therapy, it's just music that you like and that soothes your soul and grounds you. Walking out in the dirt with your bare feet. I mean, getting out in the sun and looking at the mountains or looking at the sky or watching the birds or walking on a trail or whatever it is that helps you to find connection with the universe and with other people.
Carson, we have a request to go back to the previous slide for just a second.
Okay.
So there it is for the person that asked, and I believe these slides are going to be distributed to everybody.
Good.
But there we are. It's the quote from the Kabat-Zinn. Is that how you say that?
That'll work.
Okay.
Yeah, I think he is. He is. I'm trying to think of. Oh goodness, I lived in the Middle East forever, and it's a certain faith group that I really love. A lot of wonderful poems come from this tradition. But anyway, yeah, you can look him up, and it'll give you information. Got a lot of wonderful teachings.
Thank you. Well, I'll see if I can get back to the right slide. Is that where we should be?
Yes, it is. Yeah.
Okay.
So
Thank you.
some spiritual practices, breath prayer could be just a portion of some text that is meaningful to you, or it could be a word. Some have used a psalm, that just a portion of a verse, and just doing that. But just breathing alone, my yoga experience has really helped me to get focused. For a while there, I'd wake up at night and can go back to sleep. And so I just started breathing. I'd count to 4 in my mind as I would breathe in and then breathe out at the count of 4. And it really mimicked my sleep state, my breathing during sleep. It's amazing how much that would calm me. Now, if I do that, I don't know how many times I do it because I fall asleep, and you would be amazed at how much just breathing alone can encourage that mental, emotional, and physical health as well as your spiritual. Meditation, similar to breath prayer, I guess, but on a word, a passage, a thought, centering prayer, silence, stillness. In that emptiness, your mind wanders, but this is a practice that can really, really, I think, help in just finding a still, quiet place. And that might mean moving away from your family and finding a room, and music might be whatever it takes, but to meditate. And yoga is filled with those kinds of practices as well. So well-being is not the absence of health problems or brokenness. Well-being is what you choose, again, that word choose, at the center of your life to do with these frustrating conditions. And that was written by a person in my field probably 30 years ago, but it still rings true to me today. So rest, renewal, reconciliation. I think that obviously is something we've got to figure out a way to fit into our day. And improved spiritual well-being has that positive effect on recovery from compassion fatigue. Enhanced skill development positively affects it. Coping with that improves with rest and renewal, and with greater self-understanding and the practice of good self-care. So support. How do you get support from yourself and from others? I think sometimes just by saying no, by letting people into your circle what you're feeling, and being in theirs as well. So receiving supervisory reports, so whoever you answer to in your work, organizational support, being aware of your own triggers, and then knowing what the healing that would tend to that would be, responding to symptoms, and having a plan. It's going to happen, so have a plan. And Stam's challenge is to all of us to learn to transform our encounters with these things, all of the things that we experience during the day, into opportunities for growth for ourselves and for those whom we seek to heal. And one other thing I want to say that I think can be helpful is to realize that this is a part of life. There's a great book written probably 20 years ago, but it was about necessary losses. Viorst is the name of the author. The fact is, we are only going to be able to build our resilience by the ways that we acknowledge our losses, we grieve them. Grief is another word for heal, and then move on to another area that can then give us the strength the next time something happens, not to be blown away from it as easily. So thank you for listening. We're out of time, but I think, I don't know, it's about 3 o'clock, but we have time for questions, Susan?
We do have time for questions. I haven't seen anything come through the chat, but feel free, participants, to go ahead and put questions in. In the meantime, I always have questions. I want to thank you especially for the reminder about gratitude. My research on gratitude is that it's evidence-based for reducing depression, burnout, compassion fatigue, all of that. And recently I came across a quote that has really, it resonated with me in the sense of I'm trying to make it an action plan. And it is from a deaf educator named Jean-Baptiste Missou. Are you familiar with him, Carson?
Yes, I've heard of him.
So the quote is, "Gratitude is a memory of the heart." And so I thought that would be a good thing for me to try and be intentional with moving forward. So that's one thing. The other thing that I noticed about your presentation, you didn't use the phrase self-compassion, but the concept was certainly woven into it. And there's a website called selfcompassion.org with resources, tools, and tips to help us remember to be compassionate to ourselves. So I thought I would share that.
Thank you. I'm going to look that up. Selfcompassion.org.
Yes. Mm-hmm. Yeah.
Fantastic. Thank you.
I think a lot of times clinicians, because we have a heart for people and for others suffering, we overextend ourselves. And I love your reminder. You shared your example of intentionally checking in with yourself. I think you took the PQOL a few weeks ago. And I thought, maybe I need to schedule regular check-ins with myself, just like I do with family members and even with clients. But, just being intentional and saying, once a month, I'm going to sit down and I'm going to assess myself and my needs. So I don't see any other comments in the chat. So thank you so much, Carson. Toya, if you didn't already put Carson's contact information in the email, in the chat, can you do that? Okay. Thank you so much, Carson.
And thank you, and thank all of you. I see some of you I know. Hey, Mary. I'm glad to be with you today. Wish you well. Thank you.
So Toya has put information in on completing the survey, which is you have to do to get your CE certificate. And we're gonna, at this point, ask Mary Miles, who is our advisory board chair, to address our group. Also, Mary's gonna announce the winners of the certificates for $25 off next year's mental health symposium. And before I forget, if you haven't typed your name and licensure in the chat, please do so now. And if you'll bear with me, I'm going to see if I can find Mary and bring Mary up. Where is Mary?
I'm here.
I hear you. There you are. Hi, Mary.
Hi, Susan. Thank you so much. I promise I'm going to be very brief because I know everybody's really kind of exhausted after this long sitting in front of your computer. So, but there were several things I wanted to do. I wanted to thank, of course, all of you for coming and participating in this. I can't believe it's our 5th annual symposium on mental health issues. So it's really amazing that we could get it all pulled together virtually and, well, not terribly short notice, but still with the work of a lot of people. And those particularly include Toya Hancock and Nelda Hope, who are with Spartanburg Regional Health Systems. They're in the corporate education department, office, whatever. Anyway, they are the ones that are our partners working with Mental Health America of Spartanburg to bring this together. Erica Johnson, who works with the Mental Health America, she's what I call our social media guru, but she has helped with all of this slide preparation and a lot of the work behind the scenes. Sally Owen, Vanessa Thompson, and I are all on the advisory board for Mental Health America of Spartanburg County. And especially I want to thank Susan Lee, who is also a member of the advisory board of Mental Health America Spartanburg, and has just been doing an amazing job in helping us move into the virtual world with so many other organizations. And she's put a lot of time and effort into this, and I've told her that her expertise from her professional background has made such a difference, I think, in terms of being able to help all of us understand it and hear these wonderful speakers. So, and thanks to her new employer, Regenesis, who has allowed her this time to do this. This was something that was planned before she changed positions and is working with Regenesis now in a school. So this is something that we've really appreciated all that she's done for us. Especially, again, our presenters, Courtney, Lori, Shakita, Carson, and Roger. And Susan has been recording all of these with the permission of each of our speakers. We are recording this, and we will figure out how we're going to make this available. These presentations have been wonderful. They need to be more widely available. We may be putting them up on YouTube. We'll send you notices about that. Of course, people viewing them will not be able to get the CEs that all of you who are here today will be able to get. So, but we will be trying to share this information more broadly. That's about it. I mean, thanking everybody again for all of your work in bringing this about and all of your time and participation in the event. Nelda and Toya, who are at the hospital in their office, did a random drawing. They had the names of everybody who's registered and participating today. And what they have come up with two winners, who will receive a $25 gift certificate towards the registration for our 2021 Symposium on Mental Health Issues. We don't have a date yet, but we will probably be doing it again in October. So congratulations to Faith Burke, who is a family nurse practitioner with the Charles Lee Center, and Kate Landsberg, who is an LMFT, which you all know what that is, with New Horizon Counseling. So Kate and Faith, as I understand it, Toya will be sending you a certificate, a gift certificate for next year, and we hope you'll plan to attend. So thank you again, and especially Susan, and I'll just turn it back over to you to any final words.
Thank you, Mary. Let's see. Gosh, you'd think I would be more versed with this by now. There we go. So I think most people have put their names and alphabet letters in the chat. If anybody has questions about CEs, please contact Toya. And certainly any advisory board member, we can help make connections on those things as needed. I'm going to leave the chat open, the meeting open for about 5 more minutes to allow people, if they needed to go back and get other, anything they overlooked, any resources. But I will go ahead and sign off at this point. It's been a long day. And I thank everybody for joining us, and I look forward to seeing you all in person next year.